Medical Council, former Head Department of OBG RIMS, and Dr. C.H. Magnan, Consultant Gynecologist and Managing Director, Imphal Hospital Research Center. Dr. Suboda. Okay. President IOGS, please chair the session, sir. Loigre, sir. Loina Loigre.
Okay, I can leave now.
MTQ session ki Loigre, sir.
Good afternoon, everybody. After a full stomach, we'll start the afternoon session. And the speaker is none other than one of the most popular contemporary doctors around in the state, Dr. Shyam Kumar Lystrom. He's MD Pediatrics from AIMS Delhi, FIFE, FPAI, FCGP. He's Director, IMA CGP Faculty of Manipur. He's past President of PAM, past President IMA Manipur State Branch, past President EZAP. He's a Senior Consultant in Imphal Hospital and Research Center. He's also National Trainer on IYCF, BPNI, Breastfeeding Promotion Network. Sir will speak on neonatal resuscitation, which is very important for all the obstetricians. Please go ahead, sir.
Thank you for kind introduction, and thank you the organizers for giving me the opportunity. So I'll be talking on neonatal resuscitation. Birth of a newborn is a potential medical emergency. 10% needs some intervention and 1% needs experience and specialized attendance. Need of resuscitation at birth cannot always be anticipated, but assessing the perinatal risk factors, more than half of all newborns needing resuscitation at birth can be identified, and accordingly we can plan it. Personnel to be present at delivery room, many times this is found to be absent. At least one person capable of initiating resuscitation and positive pressure ventilation, and an assistant for giving chest compression. This could be even the nurses who are trained in the neonatal resuscitation. IAP is continuously training not only the doctors, even the nurses. They are experienced many nurses are experienced in this NNR. But for advanced resuscitation, where we need intubation, medications like adrenaline, then the positive pressure ventilation through endotracheal tube. This needs a little expertise. They need to be trained on the advanced neonatal resuscitation, and he should have all the complete resuscitation skills and one or more to assist. This could be anyone, but they should be trained on helping, on assisting also. So equipment for resuscitation, this should always be kept ready. Many times we didn't check it, and when they need that, where is the ambu bag, where is the oxygen, where is there, and the people, and many times it makes a lot of chaos. So what we need is stethoscope should be there, clock with second hand, because we are counting the heart rate for only the 6 seconds or only 10 seconds, and the multiplied. And suction should be always available, whether it could be electric or foot handled or bulb mucus extractor. Even release mucus extractor could be placed. Catheter suction F number 5, 8, 10 back in the marks with the reservoir. Many times without reservoir, when we need to give 100% oxygen, reservoir is needed. Either it may be corrugated one or it may be bulb type. Otherwise, we can't give this oxygen 100%. We are giving 21% from the room air. If we don't put the reservoir, only 41% of the oxygen saturation will be there. And we should have laryngoscope number 1, 0 and the 1. It should be flat bed. Endotracheal tube of different sizes, 2.3, 3, 3.5. 4 maybe sometimes needed when the baby is quite big, more than say 4.5 kg, etc. So we should keep ready scissor, thread, cord clamp, injection epinephrine, disposable syringe 2 ml, 5 ml, 10 ml, insulin syringe, normal saline injection, at least 100 ml, but we can keep feeding tube number 5 and the 6, pulse oximeter and the oxygen prof if available. And these oxygen prone pulse oximeter, they are in the advanced resuscitation. So what we need are the steps we have to prepare that there should be warm. Many times we pediatricians we think of the AC and for our comfort only, but at least the temperature should be around plus 20 degree. And the positioning of the baby, as soon as the baby is brought, we should properly position the baby, clear airway as much as possible, and try and stimulate to breathe and evaluate respiration, heart rate, and the oxygenation. From the color Afghan score we can use, though still there are a lot of deficiencies in that, but still we are using Afghan scoring. So stimulation of the baby at birth, many times there is vigorous stimulation. Sometimes we found the surgeon doing more of gender discrimination. This is boy, you see this, seeing the private part, and the child is upside down. There is increase in the intracranial pressure, and chance of intracranial hemorrhage is there. So there should not be any vigorous stimulation. There should be no shaking, no hot or cold water sprinkling. But if there is persistent apnea, don't waste time. Start post-pressure ventilation. So we count Afghan score at 1 minute, but we should be very careful. The breathing should be started as much as possible. Once breathing is started, the heart also automatically will go on. So this is just some pictures showing where we can keep the one person seeing the chest and the abdomen, listening with the stethoscope, and one is endotracheal tube, and we should keep place for all the attendants. They should be able to see the chest and the abdomen. Many times we have found that our view is obstructed by the one who is assessing the resuscitation. So positioning of the baby, the child's neck is, the kinking should not be there. If there is extreme flexion or if there is extreme extension, there are also blocking of the airway. So it should be like a snipping position, slightly placed so that the airways are straight pattern. So the first one upon is the correct one, the below two bottom, they are incorrect position. I'm just saying the same thing, same slide, okay. So the A is the correct position, other B and the C are either overflexion or overextension. So we should use suitable use of correct mark. It should cover the nose, not the eyes and the chin properly, but many times we found that there is a round form also, or a little this, what to say, pointed one also. But we should keep the proper, because of size again, because whenever we give positive pressure ventilation, we need airtight one marks. So there are different marks with even a flattened pumping one rim with like just like tubes. But we should keep proper for the 2.5 kg, for 3.5. It should directly fit and it should not discover the eyes, and the chin should be properly closed also. So correct way to give free flow oxygen. Many times either we can give positive pressure ventilation with the marks, but what we found is sometimes the oxygen connection is there. We just put the bag and the marks over the mouth and the nose. That means the child is suffocating, because when we press, the valve is open and the air comes out from just below before the valve. So sometimes I found giving the oxygen, just pressing and the not pumping, then all the oxygen will go backward towards the reservoir. And another we could use like this, we are using in a nebulization machine. Another, so we don't wait for the marks, etc. to give oxygen. With our hand, we just put the oxygen tip here, tip here, and then we put it, and our hand is used as mark. So we can use this one. So all the three are correct. The hand, using the hand is also correct. So giving the positive pressure ventilation, I am just showing this slide because the one who is doing this positive pressure ventilation is from the top of the head, and another one assisting is there, and no one is obstructed from the view of the chest and the abdomen. So we just repetition, visualizing chest movement during assisted ventilation is very much important. Position yourself at the baby's side or the head to use a resuscitation device effectively, leaving the chest and the abdomen unobstructed for visual monitoring of the baby. So figure A and the B are correct. And this one, figure C, it will obstruct the view. So positive pressure ventilation is very much important. What we do is, when the baby is not crying, then the one eating that does, squeeze is not like that. We need certain time, and so we have to count out loud to help maintain a rate of about 40 beats per minute. Safe breath. When we save breath, we squeeze the bulb, then we release the breath while we say 2 and 3. What usually we do is 2, 3 breath, 2, 3 breath, or either 2, 3 squeeze, 2, 3 squeeze, not a squeeze. Many times we found that we are doing, when the child is not crying, just pressing very, very fast. So it's unnecessary, it's ineffective. So 2, 3 breath, or squeeze, 2, 3 breath. 2, 3 breath, we should count it loud. So when positive ventilation, when the heart rate is below above 60 per minute, we can do this positive ventilation without intubation. Once it is below 60 beats per minute, then we should do intubation first. Then we do the chest compression just below the nipple line. Either we can do with the two thumbs, the hand, both the fingers below the baby's back, or another we can use 2 fingers, middle and the index finger. This is the point of chest compression. I have shown the xiphoid, then sternum is a nipple line. Just below the nipple line, if we press a little down, there will be tear of the xiphoid also. Just below the nipple line we should do. Either we can do like this, or we can do like this. Okay. So here we do once again. Here also the same is with the chest compression, ventilation. But here when chest compression, what we can do is 1 and 2 and 3 and the breath. When the breath is there, I should release the hand, and the one will squeeze it. And we should not lift our fingers or thumb from the baby's skin. It should be kept intact, but we would press at a time. The exhalation will be there, and if we will remove away from the baby's skin, then there may be an ineffective ventilation, ineffective chest compression, or there may be a bruise, etc. So we have to do is 1 and 2 and 3 and breath. Then 1 when I release the squeezing, then 1 and 2 and 3 and breath. So we can repeat it. So we won't take much time. Once intubation also, we should be very fast. We should do very fast because we can't wait. One child is apneic, and if we know that child is having apneic, no need of waiting, and we know there are conditions. If we anticipate there's a diaphragmatic hernia, we should not do positive pressure ventilation with background mask. We should directly do intubation. Otherwise, also stomach compression, stomach expansion and distension, and lung compression will be there. So there are a few medications we need to keep in handy. Injection epinephrine is available in the OT. The recommended concentration is 1:10,000. It's available either is 1,000. Usually here there is 1 in 10,000 also, but we make a dilution, say 2 ml. Then just 9 times if we add, then it is 1:10,000 it comes. So we should make it a dilution fast. Okay, the indication is when the heart rate is below 60 beats per minute and after 30 seconds. So if effective assisted ventilation, preferably after endotracheal intubation, and at least 45 to 60 seconds of coordinated effective chest compression and effective ventilation. So the recommended route is IV. It should be very fast, or even we can give endotracheal route only while IV assist is being obtained. Usually we give through the umbilical vein. So we dip feeding tube number 5 or 6. So we give through the umbilical vein. Usually it's very fast because cannulation, it may take time also. Sometimes we are not ready to, it's not ready also. So before we take cannulation, we can just push, and it should be very fast. If the child is not improved, it can be repeated every 3 to 5 minutes. But endotracheal tube, once we give, then we should put a little normal saline, and we do a little more ventilation so that it will go through the bronchi and the bronchioles. Otherwise, it will be only in the trachea. So the recommended dose is 0.1 to 0.3 ml per kg, or consider 1 ml kg if endotracheally, and may be repeated every 3 to 5 minutes. Thank you. I am not taking much time because all must be quite tired. Thank you very much.
Thank you, sir, for your beautiful deliberation and very useful practical tips. I think we can entertain a couple of questions from the crowd, if there is.
Thank you, Sam Kumar.
Please. So, all men, give me the opportunity. All men.
Very knowledgeable.
Anyway, in fact, when I was doing my PG and all, the baby resuscitation was a tough thing, and I don't know actually. And thanks to your team, when I am Jennings and all, they have started teaching us. So I was pressing hard, and it should be like this. But anyway, kindly continue it, and all the procedure students of obstetrics and gynecology, they should know it. Otherwise, their certificate may be a few lacuna may be there. So my humble request to all my gathering, all my learned colleagues, please try to give the real knowledge of baby resuscitation, because our good enemy, he comes for 1 hour because he have to send out his daughter to the airport. We cannot help it. But we poor gynecologists are the person who deal it directly and immediately. I think all my 2 colleagues must be agreeing my point. Thank you. You have done a wonderful, wonderful job. Thank you.
Thank you. And just to complement, we, Indian Academy of Pediatrics is doing, it's one of the largest projects in the world, and it's called NRFGM, neonatal resuscitation in the first golden minute, not first golden hour. And here we have trained lot of even RIMS PGs. Many of the PGs also have been trained in pediatricians, SR, even interns, and many nurses have been trained all over the state. And our Dr. Basanta is one who is quite appreciated by the headquarters, Central IFP, and we continuously training it, and many have been trained, and the nurses are very much expert in this also. And one problem is when the nurses, when they do for the resuscitation, that we doctors are saying, come on, I will do it, but he doesn't know. Actually, if I am not trained, I won't know. But the nurses are trained. Sometimes we have to respect their expertise also. So we tell them, to the nurses, we empower them, sir, I have been trained here, let me do like that, okay. This also, I think we could respect those who are trained, who are experts. Thank you.
Dr. Shamkumar, we are grateful for your wonderful presentation, but I just want to clarify something. One is, what should be the depth of the CPR in a neonate?
Pardon?
Depth of the CPR, how far we have to
It's
compare?
about 1/3 of the chest compression. To shorten the time is 1/3 of the chest compression.
Secondly, is there any point?
Chest anteroposterior diameter.
Is there any end point for CPR in a neonate? Say for so many minutes, so many hours, in terms of heart rate and the respiratory rate?
Yeah, see, but you know, sometimes heartbeat, till the heartbeat is there, it may be, still we try continue it. And the child's brain and the heart is something that sometimes they might have GA sedation to the baby also. So we continue till the heartbeat is there.
So there is no end point?
No end point, till the heartbeat is there. So we give adrenaline, that also will improve the heart oxygenation functions also.
Thank you, sir, once again, and thank you again for finishing well within time, since we are short of time also. Thank you, sir.
Thank you. Thank you.
For the next topic, I hand over my mic to sir.
It's time for all of us to welcome Dr. Amit Mandal, if he's around. Dr. Amit Mandal. Amit Mandal, he is affiliated with Fearless Hospital, Kolkata, West Bengal. And he worked there as a consultant in oncology. He had a brilliant career with various equipments. Just to name few, he was invited as foreign faculty for hands-on training in gynecology, oncology in the country of Bangladesh. He was invited as faculty in state and national conferences all across the country. And he received the Best Paper Award in FOGSI in 2017, and also Best Paper Award in the 17th World Congress for Cervical Pathology and the Colposcopy in IFCPC India 2020. Besides this, he won many national and international publication awards. Now it's time for us to welcome Dr. Amit Mandal.
Thank you, respected chairperson. Today's topic is GTN, most controversial topic among the gynae and obstetricians, actually. So I will brief my talk over these contents. So gestational trophoblastic disease was first reported in 400 BC. That was known as dropsy of uterus at that time, and methotrexate in 1971 it was first reported. So gestational trophoblastic disease can be divided in these following heads, as we all know. The new thing is atypical placental site nodule, though I have not encountered in my career this entity. About 50% GTN follows a molar pregnancy, we all know. After evacuation, 2 to 6% of partial mole and about 13 to 24% of complete molar gestation will progress to GTN and require chemotherapy. So this is the NCCN guideline. We can see the criteria for diagnosis of postmolar GTN, FIGO criteria or NCCN. These are all I think we know. 4 or more plateau measurements over a period of 3 weeks or more of beta HCG, and rise in beta HCG for 3 consecutive weekly measurements over at least a period of 2 weeks or more, or histological diagnosis of choriocarcinoma. Again, during assessment, we must take a thorough history examination, particularly the presence of suburethral tumor nodule, and we should work up, a metastatic workup should be done to stage and score the disease. So among investigations some blood investigations are required with USG and Doppler. CCT picks up 40% cases missed on chest X-ray, but the FIGO score takes only the chest X-ray scoring, not the CCT scoring. So the presence of lung micrometastasis does not influence the outcome. If lung metastasis is present, so MRI or CT brain is required. And there are various chest X-ray appearances except the cannonball appearance like pleural effusion embolic pattern. So nowadays the role of uterine artery Doppler is there. We should calculate the pulsatility index, that is vascular resistance, which shows if less than 1.1 is associated with chemoresistance to methotrexate. So we can assess. And there is also the role of embolization. Actually, we can avoid the hysterectomy in some cases, those who are young, and it is indicated in only 2% of them may require treatment due to refractory vaginal bleeding. In that case, embolization can be done. And what is the role of second curettage? It is most controversial, and there is no robust data. But chemotherapy requirement was more likely for patient with a histological confirmation of persistent trophoblastic disease and for urinary beta HCG in excess of 1500 international unit per liter at time of second evacuation. Then the Cochrane review suggests there is no role of prophylactic chemotherapy because it increases drug resistance. And this is the scoring we all know. And there is, we have to think about these two scoring. Intermediate risks 5 to 6 and ultra high risk. Actually, chemoresistance in low risk patient 10 to 30%, those who have intermediate score of 5 or 6, and ultra high risk is greater than 13. These patients have very high disease load and increased risk of mortality with conventional multi-dose regime. And this is the staging we all know. This is the NCCN guideline for the low risk GTN. Methotrexate is ideal to start, though dactinomycin can be used in some cases where there is methotrexate toxicity or effusion, contraindicating the use of methotrexate. And Cochrane review suggests actinomycin D most likely to achieve a primary cure, but due to its adverse effect, methotrexate is generally recommended. And change to multi-agent from single-agent chemotherapy, we all know beta HCG rise after single-agent chemotherapy, resistant to sequential single-agent chemotherapy. So the definition of chemotherapy resistant is indicated by plateau in beta HCG over 2 consecutive cycles and development of metastasis. So this is the for high risk GTN. IMACO is the regime. About 20% of the patients do not attain complete response with IMACO. And ultra high risk gestational trophoblastic neoplasia, here massive disease starting with standard chemotherapy may cause sudden tumor collapse with severe bleeding, metabolic acidosis, myelosuppression, septicemia, and multiple organ failure. So induction chemotherapy with etoposide and cisplatin on days 1 and 2 to be repeated weekly for 1 to 3 weeks before starting normal chemotherapy. And these are some salvage therapies, and EMA, EP, all these are salvage therapies actually. And now the role of targeted therapy. Actually PD-L1 or PD-1 inhibitors are now in use, but there are some phase 2 trial mostly. And what is the role of surgery? Generally hysterectomy should not be done, but hysterectomy can be considered only in uncontrolled uterine bleeding, although it can be avoided with the use of uterine artery embolization. And laparotomy in case of where to stop bleeding in other organs, and neurosurgery for bleeding in the brain or increased intracranial pressure. And resection of an isolated drug resistance tumor may also be curative. So in case of lung metastasis, one thing the intensivist must know, that is the positive pressure of ventilation may incite more pulmonary hemorrhage in these cases, so due to friability. So positive pressure ventilation at low pressure is the class to prevent hemorrhage. And in brain metastasis, we have to increase the methotrexate dose, and also whole brain radiotherapy in some cases can be used along with after chemotherapy. And in case of liver metastasis, the choice of chemotherapy is EP, etoposide and cisplatin for 1 to 3 weeks, followed by EMA-EP. And management of bleeding from other areas, we can give the expectant management for vaginal metastasis and bleeding from there, and also vascular embolization. And NTT, PSTT, ETT, though rare, but it is less chemosensitive and greater propensity for lymphatic spread. And FIGO score is not indicated here. We must not calculate the FIGO score in these two entities. So at diagnosis, metastases are mostly noted about in 50% of the cases. And the most important prognostic factor include advanced disease stage and interval from the last known pregnancy. And hysterectomy, self-ingectomy in case of non-metastatic disease. In metastatic disease, hysterectomy with self-ingectomy and chemotherapy are recommended. And here the follow-up is not by beta HCG, it is by PET scan ideally. So, and there is, as I already told, there is role of checkpoint inhibitor, pembrolizumab also. Over 80% of choriocarcinoma and about half of PSTT, ETT express detectable PDL1. So we can use the pembrolizumab. And this is the phase 2 trial, which is with avelumab. And so we must consider the long-term toxicity of chemotherapy. It is very important. Menopause get advanced by 3 years after combination chemotherapy and 1 year after single agent therapy. And risks for developing secondary malignancy are also common. And follow-up schedule, we all know, for low risk GTN, follow-up with monthly beta HCG for 12 months. For high risk, follow-up with monthly beta HCG for 2 years. And PSTT, ETT up to 5 years. Beta HCG with imaging PET-CT. And contraception is advised for a period of 12 months post-treatment with chemotherapy in any patient. So my take-home message is color Doppler indices can pick methotrexate resistant disease, no role of prophylactic chemotherapy. We can treat ultra high risk with caution, we must treat, and selective embolization an alternative option to surgery, and risk scoring not applicable to PSTT or ETT, and there is evolving role of checkpoint inhibitor. Thank you.
All of us, everyone in the hall, we were really enlightened by your excellent presentation. Now
Thank you,
the
sir.
topic is open for a few comments and queries from the floor. There is no question, no comment. Just to keep the ball rolling, the highest incidence of this type of disease is recorded in the country of Taiwan. And we in India, in Manipur, as a part of the country, we have an incidence of 1 in around 430 pregnancies. I don't know what is the incidence in states like West Bengal.
Actually, exact incidence I can't say, but it is about 4 in 300 or 350.
Okay.
Because we are getting most of the patients. Even I get the PSTT also, 2 to 3 cases.
Okay, thank you. So we wind up this discussion.
Yeah.
Thank you.
Thank you,
Dr.
sir.
Zonal. Thank you.
Now we go on to the next topic. It will be presented by Dr. Thingom Regina. She passed her MD from PGI Chandigarh. She is ex-senior resident from RIMS Imphal. Now currently she is senior medical officer specialist in government of Manipur. Her area of interest are high risk pregnancy and infertility. And Dr. Regina will talk on antenatal steroids and the fetus. Now please.
Good afternoon, respected chairpersons and everyone present here. I'll be talking on antenatal steroids and the fetus. First of all, why are we discussing this? The first point is because of the unmatchable benefits that we get of corticosteroids when given to preterm infants. And secondly, to know what is the correct way to use the steroids, the optimal timing window, the use of rescue doses, and what type of steroids. To learn on this, I'm presenting this topic. Complications of preterm birth is the largest cause of newborn deaths and deaths among children under 5. Respiratory distress syndrome, which is one of the complications of preterm birth, is the primary cause of early neonatal death and disability. It affects up to half of the babies born before 28 weeks and a third of babies born before 32 weeks. Maternal administration of antenatal corticosteroids before anticipated preterm birth is one of the most important interventions to improve neonatal outcomes. There are some difficulties which we face as obstetricians. Firstly, how do we predict the precise timing of preterm birth? How do we know that this mother is going to deliver within the next 7 days or within the optimal time window of 24 to 48 hours? Next, to know the effects of suboptimally timed dose regime administration. This is also one of the difficulties that we face. What is the role of incomplete dosing? What is the role of rescue? Does that give benefit as much as we are supposed to get? And the third point which I want to emphasize is that earlier we were more focused on sensitizing the obstetricians to administer steroids. Now the picture is regarding the overuse of it. Most preterm infants are exposed to antenatal steroids, but only 20 to 40% receive them within 1 week before birth, which means that 60 to 80%, which is a huge number, is not receiving the benefit which we aim to give. How does this work? Following the landmark study of Liggins and Howie in 1972, the impact of ACS on fetal lung maturation has been extensively studied. Thanks to them, the mechanisms are many, but most important are increase in surfactant production by the alveoli and acceleration of parenchymal changes, wherein the antenatal corticosteroid exposed lungs are structurally more mature than unexposed lungs at the same gestational age. Whom to give? RCOG has updated this guideline in July 2022, in whom they have said that it should be given to women in whom imminent preterm birth is anticipated in the former established preterm labor, a preterm pre-labor rupture of membranes, or wherein we plan a preterm birth. The Society of Maternal Fetal Medicine in 2022 have added that it can be thought to be given, it can be considered to be given at 22 to 23 plus 6 weeks, which we refer to as pre-viable period, if the family is willing for resuscitation and that the resuscitative and the stabilization facilities are available where the birth is going to take place. Even RCOG says so that it can be given in pre-viable period, but the cutoff is not given. Hence, I have quoted Society of Maternal Fetal Medicine recommendation. A Cochrane review in 2020 has clearly shown what is benefited and what has not when it's given to mothers who delivered within 7 days at period of gestation from 24 to 34 plus 6 weeks. The perinatal death and neonatal death significantly reduced. The respiratory distress syndrome, which we don't want, is significantly reduced. The intraventricular hemorrhage is also reduced. The birth weight, which we are worried about, wherein some studies have said that administration of steroids leads to low birth weight babies. It does occur, but it is not that significant that it should stop us from administering them. However, a slight reduction is seen in developmental delay in childhood in terms of intellect, hearing, and vision. ACS does not seem to increase the risk of maternal mortality, chorioamnitis, or puerperal sepsis, and this is another plus point for us. The pre-viable period, which I have already talked about, it should be considered in scenario where neonatal stabilization and resuscitation will be carried out. The significant reduction in neonatal mortality is seen for 22, 23, and 24 weeks. However, the reduction in intraventricular hemorrhage is not seen for 22 weeks. It is seen only for 23 to 24 weeks only. when to administer, the timing of administration. All above reduction of benefits is seen when the birth occurs within 24 to 48 hours after starting treatment. What if the woman delivers within 24 hours? Partial benefits are seen, so we can still give the steroids. The reduction in respiratory morbidity is likely if birth occurs 7 days of starting treatment. Please note, not mortality and not intraventricular hemorrhage. So we always say it should be given within 7 days to take the benefit of reduction in respiratory morbidity, not of other things. Coming to late preterm, that is 34 plus 6 to 36 plus 6 weeks, a study was conducted named as Antenatal Administration of Steroids to Late Preterm Study. It has found that the neonatal composite outcome, the unwanted outcomes, have reduced. Transient tachypnea of newborn, surfactant use after birth, bronchopulmonary dysplasia is also reduced. The need for respiratory support also is likely to be reduced. There is no significant difference in chorioamnitis and neonatal sepsis. However, the incidence of neonatal hypoglycemia is increased when given in late preterm. So whenever we are considering it, please consider in the light of risks versus benefits. The doses, the recommended doses are for betamethasone, 12 mg intramuscular repeated after 24 hours, 2 doses only, and for dexamethasone, 6 mg IM every 12 hourly for 4 doses. Which one is better, dexamethasone, betamethasone? Dexamethasone is cheaper, easily available. It is available as a single salt, that is phosphate. More reduction in intraventricular hemorrhage is seen in some studies compared to betamethasone. However, it requires multiple doses and a longer duration to add. Betamethasone is costlier. It is available in different salts. It is available as acetate, it is available as phosphate, or as a 50-50 mixture of acetate and phosphate. Whatever studies RCOGA and Society of Maternal-Fetal Medicine have studied, it is a 50-50 mixture of acetate and phosphate. However, it is not available in India. This is the main concern we have. Lesser chorioamnitis and better neurodevelopmental outcome, deafness in pre-viable babies is seen with betamethasone. However, more of neonatal hypoglycemia is seen with it. More than 2 doses is required if BTN phosphate is used. This is according to the National Health Mission Government of India. They have said that since acetate phosphate 50-50 mixture is not available in India, what we are available with has a shorter time. So we need more than 2 doses for it. 2 doses of BTN phosphate is not sufficient if we are giving it in India. Also, the incidence of neonatal hypoglycemia seems to be more than betamethasone. Taking everything in note, the government of India has said that dexamethasone appears to be more appropriate in our settings. Coming to rescue dose. Rescue dose, is it a compensation for us for not giving it in the optimal time window? Rescue dose administration was first postulated to increase the number of optimally timed ACS administration, but studies have found that no significant difference is seen. Rescue dose should be given if the treatment is more than 7 days ago, since it increases the benefit of reduction in respiratory support after birth. However, it likely to reduce the birth weight, head circumference, length, and neonatal blood pressure. Some concerns that we have is, number 1, maternal glucose tolerance affected for up to 5 days. As already mentioned, for 35 to 36 plus 6 weeks, it increases the neonatal hypoglycemia. Thirdly, it seems to reduce the birth weight if birth is more than 7 days after administration of steroids. And lastly, it appears to increase the psychiatric and the behavioral diagnosis if children is born at term. Some special cases where we should administer are mother with diabetes. It can be given, but an additional insulin dose should be given to compensate for the hyperglycemia that occurs, and the women should be informed. For mother with hypertension, yes, it should be given. Earlier, we used to think that the number of stillbirths increased when ACS was given to mother who are hypertensive, but now it's clearly been said that nothing like that occurs and it should be given. Mother with multiple pregnancies. We have very little studies on women with multiple pregnancies, so we give it in line with recommendation of singletons, and this should also be conveyed to the mother. Mother with fetal growth retarded with restriction fetus. The higher rates of survival without disability at 2 years corrected age and reduction in neonatal mortality is seen, and hence it's recommended. This is the infogram given by RCOG when we are planning to give antenatal corticosteroids at term before planned cesarean section. Some people give when we are planning cesarean section at 37 to 38 plus 6 weeks. For this, we are supposed to have an informed discussion about the potential risk and benefits. The reduction in respiratory distress syndrome, transient tachypnea of newborn, or admission to neonatal unit overall is uncertain. The probable risk for hypoglycemia and the potential development delay is also there. Also, the reduction in educational attainment and school age is also seen in some studies. Then why are we thinking of administering it? Because compared to vaginal births, the risks of all these are higher in cesarean section, and we have a hope that it may reduce admission to neonatal unit for respiratory morbidity. So to avoid all these confusions whether to give steroids or not give, we should plan cesarean at 39 weeks or more, not before that. With this, I'd like to conclude. Thank you.
Thank you, Dr. Regina, for your nice presentation and finishing within time. In your slide, between 34 and 36 weeks, you said you have to weigh between the benefit and risk. Can you elaborate a little more on that? How do you assess the benefit and risk?
Sir, the benefit being that if we administer at that duration of time, we can see decreased respiratory morbidity in terms of less surfactant use after birth. The transient tachypnea of newborn is also decreased, and bronchopulmonary dysplasia is also decreased. But the risk of neonatal hypoglycemia increases at that time, sir. Also, it is seen that the effect in the brain, maybe because of the rapidly increasing brain size near term, the antenatal corticosteroids seem to have some effect on it. That's why, sir, we have to weigh between the benefits and the risks, and we have to think that if patient is in more risk for having respiratory morbidity, we should give it. Otherwise, we should avoid.
So it will also depend whether you are going to give surfactant or not, whether it is.
Yes, sir.
That is also.
Yes, sir.
I think we can take a few questions from the audience if there is any, or any comment or supplement. Dr. Zen.
Wonderful presentation, Dr. Regina. Just a comment, it's not a question. Even though the RCOG has highlighted the gestational age at which you have to give corticosteroids, I feel in our settings and in individualized settings, it should be the salvage rate of your NICU that you are joining with in the hospital. So if my NICU is not able to salvage below 28, there's no point in giving any corticosteroids below 28. If I can salvage around 30, so I think it should, the focus should be more on that.
Yes,
Thank
sir.
you.
Thank you, sir. Thank you so much, sir.
Yeah, exactly. So we are giving antenatal corticosteroids around 30 weeks. Because of the much improved efficiency and efficacy of the NICU, we started lowering down to 28 weeks actually, which is practicable, seeing the ground realities in this part of the country. Even though what is written in the standard textbook is different from what we do. So we can give around 28 weeks.
Yes, sir. Even RCOG and the Society of Fetal Medicine have also clearly stated that it's to be given in where resuscitative and stabilization facilities are available.
And the mechanism of action, maybe additionally, there might be blunting of the inflammatory process in preterm birth, which is one of the factors for preterm birth.
Yes.
And there should be adequate number of beds in the NICU, which is located in the vicinity of the labrum, not like transporting the baby to long distance without warmer or something like that. Anyway, thank you very much.
Thank you so much, sir.
So with that, we come to the close of this session. Thank you.
Thank you, speakers, for sharing your valuable knowledge with us. Now I request the chairperson to kindly felicitate our speaker, Dr. Regina. Felicitations, sir. First, I would like to call upon Dr. Regina. Next, I would like to call upon Dr. Sam Kumar, respected sir, to kindly come up on the stage. Next speaker, Dr. Amit Mandal. Requesting next speaker, Dr. Amit Mandal, to come up on the stage. Moving forward, we have our next scientific session on the topic SOC. I take the honor to invite the chairperson onto the stage, Dr. C.H. Manglin Singh, consultant gynecologist and managing director, Imphal Hospital and Research Center, Dr. Raj Chandra Singh, head of department, transfusion medicine, RIMS, Imphal, and Dr. Imo Chaubi Thangzam, senior specialist, obstetrics and gynecology, Manipur Health Services. I request all the chairpersons to kindly start the next session.
Now I call upon Dr. Akum Sarda Devi. The topic of today is hemorrhagic shock. Dr. Sarda, please.
Thank you, sir. My dear respected chairmen and my dear seniors and my dear colleague, a very good afternoon to you all. The topic which has been given to me today is hemorrhagic shock. So coming to the definition, hemorrhagic shock, shock is where there is an imbalance between the oxygen demand and the supply in the body tissue. And there are different etiologies of causing the shock. We have hypovolemic shock, we have cardiogenic, obstructive, distributive, and metabolic. Today we are mostly focused on the hypovolemic shock. As an obstetrician, we face this hypovolemic shock day in and day out. And the most common of this hypovolemic shock is the hemorrhagic shock. And coming to the hemorrhagic shock, the most common cause we face is the PPH. So coming to the definition of PPH, we have gone the day before yesterday in the PPH workshop, the various definitions and the causes. So according to ACOG, the PPH is defined as loss of 1 liter of blood irrespective of the mode of delivery within 24 hours of birth. Our FOGSI used to define PPH as greater than half liter of blood in 24 hours regardless of the mode of delivery, but currently we all know that the definition has changed. PPH now is defined as any amount of blood loss that has the potential to produce hemodynamic instability. We all know the different causes. I will not go into the detail of the causes, but I'll just put that tone, trauma, tissue, and the thrombin, we all know are the main causes of PPH, of which tone is the most commonest cause of PPH, which counts around 70% of the PPH cases which we face in our labor rooms. Coming to the PPH bundle, I will not go into the details since we already have a workshop the day before yesterday. The first PPH bundle consists of the crystalloids, uterotonic ducts, and uterine massage. If it is not responding, we go ahead and do other resuscitative measures like the anti-shock garments and surgeries. So what is very important when we have a case of shock is that we should know what is the shock index of that patient. So shock index, coming to the definition, is defined as the heart rate divided by the systolic pressure. For the non-pregnant patient, it should be between 0.5 to 0.7. For the pregnant lady, we like to have it between 0.7 to 0.9. Why are we giving so much importance on shock index? Because if it is more than 0.9, then the mortality, the death rate of the maternal mortality increases drastically. So again, when we have a case of shock, we should remember the rule of 30. So what is the rule of 30? That is, the shock develops when there is loss of 30% of the blood volume, and there is fall in the hematocrit by 30%, and if there is fall of the BP by 30%, and the increase of the heart rate by 30 beats per minute. We all know the classification of the hemorrhagic shock: type 1, type 2, type 3, and type 4. Type 1, we don't see much changes, but we just see that the patient are getting a little bit anxious. In type 2, we see the patient is having increased heart rate, tachycardia. In type 3, we find that her BP is dropping. In type 4, all the parameters are distorted. So how do we manage when we have a shock patient? What do we do first? First, we check we do the ABC, that is airway we check, then we check the breathing, and we see the circulation. So when we have a shock patient, we make sure that we put the two IV cannula which are of large bore. We either a 14 gauge or a 16 gauge. So it is usually the green color which we have in our emergency tray in our labor room. So, and we also put a Foley's catheter to measure the urine output. When we put the IV cannula, before connecting to the drip or the IV crystalloid, we are supposed to take the blood for cross-matching, and as well as for the full FBC, that is full blood count, and to screen the coagulation profile, and also to have the knowledge on the blood baseline blood profile that we send like AFT and LFT. And we should be monitoring the patient every 15 minutes. The pulse, BP, and the respiratory rate has to be monitored every 15 minutes. And if there are expertise available in the labor room, we can also take the help of our anesthetist and set up the arterial line monitoring. And it is best to transfer the patient to the HGU if the facilities are available. So how do we give the IV fluids? Can we give at any rate? Now let us come and discuss on that. Aggressive, there are two approaches. One is aggressive approach, where we are pushing the fluid and trying to maintain a normal BP. Another method is a hypotensive resuscitative method, where we are trying to maintain the baseline BP so that the vital organs are perfused. So the difference only is in the targeted management of the blood pressure. So in the permissive hypotensive method, we are trying to maintain the systolic blood pressure between 80 to 90, or the mean arterial pressure between 50 to 60 millimeter of mercury. So what about the blood? Are we going to give a blood component, and what type of blood are we supposed to give if we have a hemorrhagic shock patient which is bleeding? In that case, we should give the Rh negative, O negative blood with K negative units, and we should replace it with a patient-specific, group-specific if it is available, as soon as it is available. Intraoptic cell salvage, in this we are using it only in cases of PPH in the cesarean section and in the vaginal delivery also, where we give the autologous blood of the patient to the patient itself. FFP, are we supposed to give FFP along with the other packed RBCs and all? Yes. If we are not getting the coagulation profile and the patient is bleeding and we have already transfused 4 packed RBCs, then it is better to start giving the FFP so that the coagulation profile is not disturbed or distorted. And FFP is usually given at a rate of 12 to 15 milliliter per kg until the hemostasis states are known. So if we have the PT and APTT elevated more than 1.5 times the normal, then we might require more of an FPP, maybe more than 15 ml per kg, depending on the arrangement. What about platelet? Should we give the platelet? Yes, definitely. We should give the platelet if the platelet count is less than 75,000. Fibrinogen. Fibrinogen is very much important to maintain in a greater range, greater than 2 grams per liter, so that the patient does not go into DIC. So what do we give for that? We give the cryoprecipitate. Tranexamic acid, as we all know that for the prophylaxis, we are using the tranexamic acid in the cesarean section as well as in the normal delivery. But for the hemorrhagic shock, is it recommended? Now we have already, it's a trial is going on for that in the PPH. Women 2 trial is going on. The results will be out very soon. And I think we will be using tranexamic acid in the future. For the prevention of the PPH, we are usually giving 1 gram of tranexamic acid over 10 minutes. Massive blood transfusion protocol. Massive transfusion. What do we call? When do we call it? Massive transfusion is called when the patient has considered to be having a massive transfusion when we have already given more than 4 packed RBCs unit, or the whole blood of the patient is replaced within 24 hours, or at least 15% of the blood volume is replaced within 3 hours. So what we see that ACOG recommends giving the product in the blood products in the ratio 1:1:1, and it usually mimics that of the whole blood replacement. So here is the massive transfusion protocol. I will not go into the detail of massive transfusion protocol because in the next session we have another resource person, Dr. Himavati, will be talking in detail about that. So coming to why are we supposed to give in that particular ratio 1:1:1 is that because it has in the PROM study, that is prospective observational multicentral measured trauma transfusion study, it is said that a patient, if we give the plasma and all within the first few hours, 3 hours, then the survival is very high. And even in the PROM study, it is said that if we give, the patient death risks are very low. Coming to the damage control resuscitation, it consists of minimizing the hemorrhage and preventing the development of the coagulopathy, acidosis, and hypothermia, and maximizing the tissue oxygenation. So what do we do in DCR, damage control resuscitation? We try to give more of the blood product and decrease the transfusion of, limit the use of crystalloid and control the bleeding. Control bleeding, we can do it by surgery or a radiological intervention like DCS or DCIR. In DCS, when do we do it? When the patient's blood pressure is dropping, systolic is less than 70, body temperature is dropping less than 34 degrees Celsius, maternal pH, blood pH is less than 7.1, and there is a venous bleeding, and the patient is having persistent bleeding, there has been a massive transfusion of 6 pack RBCs or more during the first 4 hours, and the patient is rapidly deteriorating and hemodynamically becoming unstable, and if there is the surgery, which we are, even after the delivery, if you are doing surgery for more than 90 minutes, we should go ahead and do the DCS, damage control surgery. So what are the DCS? In case of the obstetric cases like PPH, we usually have a uterine compression suture, we have uterine artery ligation, we have bilateral iliac artery ligation, and hysterectomy. These are my references. I have taken points from the FIGO guidelines as well as the RCOG Green Top guidelines. Thank you.
Thank you, Dr. Vidya, Dr. Sardar, for your nice presentation.
Thank you, sir.
But one thing I want to, the topic actually is a hemorrhagic shock.
Yes,
and
sir.
you just concluded only in the PPH only. Thing is that there are many causes of hemorrhagic shock, but not only PPH. But let's go to the PPH. What I want to know is, what is the prognosis? Suppose if a patient is having a PPH at present, so what is the chance of getting PPH in the next pregnancy?
Yes, sir. The RCOG, they have done a study, and it is shown that the chances is very high. It is if the patient 1 in 4, around 20 to 25% chances is very there if the patient already had a PPH in previous pregnancy. That is the reason, as an obstetrician, as a gynecologist, we always ask whether the patient had any problem in her previous delivery. And we want to know the reason behind most of our patients usually comes for a checkup during the antenatal. They don't have checkup. Maybe they have hemolytic disorder. That is the chance when we get a chance to diagnose and treat the patient at the same time when she comes for pregnancy. So that's the reason why we obstetricians make sure to ask the thorough history when she comes.
In fact, the hemorrhagic shock, of course, is much we have pointed out. The other causes of hemorrhagic maybe ectopic or maybe the time of MTP. But one common, as my personal experience, is that in managing the shock, people used to sometimes diagnosis the other shock, also anaphylactic shock and hemorrhagic shock and septic shock. But sometimes on my personal experience or long-standing optical practice, I have seen that in 1 or 2 cases, thinking that there is anaphylactic shock, but they think that this is the misdiagnosis. They have given more of blood, more of feed transfusion, leading to more complications in the lung, overloading of lungs. So I had some 1 or 2 cases in my career that I have to. I mean to say, in management of shock, we have to first identify, apply our common sense. Is it a hemorrhagic shock, is it anaphylactic shock, or it is septic shock? Because these two treatments, anaphylactic shock and hemorrhagic shock, of course, we have to transfuse and maintain blood volume. But in case of anaphylactic shock, if we transfuse more, there is a overloading of lungs, then there is more problems. Then you have to give your drugs used to counter the causes of allergy. So I mean to say that if we apply this little of common sense, then we can avoid this problem of our patients' morbidity and mortality. Right. Yeah. Any other questions from the audience? Next please.
Okay, thank you, Dr. Sardar.
Thank you so much, sir. Thank you.
Next speaker is Dr. Kuman Victor. Dr. Kuman Victor is the Assistant Professor Obs and Gynae, RIMS,
expertise in ultrasound, infertility, and gynae endoscopy. Welcome, Dr. Victor.
Good afternoon, respected chairpersons and my dear audience. Today, topic we have been discussing on shock, and Dr. Sada has eloquently covered the part of hemorrhagic shock, and my topic today will be septic shock. So, what we call shock is actually circulatory shock. That is, because of circulatory dysfunction, there is tissue hypoperfusion. Now, there are 4 subtypes which has already been described, and my discussion will be confined to a type which is called a distributive shock, and distributive shock may be septic, anaphylactic, neurogenic, etc. Now, what do we mean by a distributive shock? The thing is, the blood volume is remaining the same, but because of peripheral blood pooling, the amount of blood received by the heart, and thereby the stroke volume is reduced. So that will subsequently lead into distributive shock. And one such example is septic shock. And I will be dealing with septic shock. Now, when we talk of septic shock, we have to, what should I say, we have to recapitulate the sepsis syndrome, which is a continuum. So first of all, what we need to know is the systemic inflammatory response syndrome. Now, clinically, systemic inflammatory response syndrome has been described when we fulfill 2 of the 4 criteria. The 4 criteria being tachycardia, tachypnea, hypothermia or hyperthermia, and leukocytosis or leukopenia. If we satisfy 2 of the 4 criteria, then we consider it SIRS or systemic inflammatory response syndrome. Now, when we have established that this SIRS or systemic inflammatory response syndrome is because of the causative thing is an infection, then we call it sepsis. So sepsis is life-threatening condition, and it happens when the immune system overreacts to an infection. So now coming to the continuum of the spectrum, next is the severe sepsis. So when do we say severe sepsis? When sepsis is associated with organs malfunction. So when there is hypotension ensues, what happens is there is reduced blood flow to the vital organs, and symptoms because of decrease or hyperperfusion to these organs are manifested. This is when we call severe sepsis. Now comes the 3rd stage, that is the last stage, that is the septic shock. And it is when there is extremely low blood pressure despite adequate fluid replacement. Then we call it septic shock. So when sepsis-induced hypotension remains refractory to initial management with adequate fluid resuscitation, then septic shock ensues. Now, how does septic shock happen? I will go into further details about the septic shock. So, an inciting agent, that is the infection or the pathogenic antigen. What happens? It causes both pro-inflammatory and anti-inflammatory immune system activation. So, it is when the infection goes into the stage of sepsis, there is always a fight between the pro-inflammatory thing to control the infection and the anti-inflammatory response of the body to achieve homeostasis. So it is the outcome between these 2 chains of homeostasis that will ultimately determine the outcome in the patient. So because of this pathogenic antigen, monocytes, macrophages, neutrophils interact with the endothelium. Endothelium is always the primary site of action in case of septic shock. And this, because of this activation of macrophages, monocytes and neutrophils, what happens? It leads to further involvement of the cytokines, proteases and kinins and reactive oxygen species, and as well as nitric oxide. So what happens? The endothelium suffers microvascular injury, and thereby there is activation of the coagulation and complement cascades also. That is why we find complications associated with septic shock when patient goes into DIC and all. So this leads to capillary leakage because of the endothelial injury. Now, as I previously mentioned, the balance between the pro-inflammatory responses, which help eradicate the invading microorganisms, and the anti-inflammatory signals, which try to keep the inflammatory cascade in check in order to maintain or go back to homeostasis, that will ultimately determine the degree of morbidity and mortality of the patients with sepsis. So there is capillary permeability, increased capillary permeability, and concomitant reduction in peripheral vascular resistance. So there is a reduction in afterload as well as reduction in preload. Because of the capillary leakage, the fluids are the fluids they are supposed to come back to the heart get trapped in the third space. So there is a resulting reduction in the stroke volume, which is initially to maintain the cardiac output. This reduction in stroke volume is initially maintained or accommodated by an elevation in the heart rate, and this is the stage called a compensated septic shock, and this is the stage where our active efforts towards management should be directed. So as a result, the patient is in a hyperdynamic state, and that is characteristic of septic shock. Usually we find patient with septic shock with hyperdynamic precordium and quick filling peripheral pulses in the initial state, where we can resuscitate the patient and bring back the patient from septic shock. So this is what happens. There is infection, then there is release of the toxins, then the host defense is activated. Now, because of this defense, there is activation of the inflammatory mechanism. So oftentimes when it is adequate, the microbial toxins are cleared and neutralized and patient recovers. On the other hand, when the response is inadequate, there is still uncontrolled infection, ongoing tissue damage and injury is there. So this will subsequently lead to shock and organ damage and ultimately to death. So when it is inadequate, the body tries to increase the inflammatory response and bring to adequate response for recovery from the sepsis. So on the other hand, when the response is excessive, in a case of excessive response of the inflammatory cytokines and other mediators, there is tissue injury and subsequently again leading to damage, cell damage, organ damage and death. So here the other component which comes into action is the compensatory anti-inflammatory response. On one side is the SIRS, the systemic inflammatory response syndrome, to tackle the infection or the pathogens, whereas the body tries to maintain a homeostasis by so that there is no overaction of the anti-inflammatory response. So we have a CARS system, which is the compensatory anti-inflammatory response system, which acts towards achieving homeostasis by controlling the excessive organ damage because of the activation of the inflammatory system. So coming to the etiology of sepsis, this is according to the EPIC-2 study, 2009, the European Prevalence of Infection in Intensive Care, whereby gram-negative bacterial infections far exceed those of other etiology. It often contributes to up to 62%, and E. coli is one of the commonest organisms causing gram-negative bacterial infection. Gram-positive infections stand at around 40 to 47%, and of late there is an increase in the prevalence of the gram-positive infections, which has been attributed to the performance of invasive procedures like central lines and this thing, and increased incidence of nosocomial infections from the ICU setup. Now, the predominant sites of infection which lead into sepsis, severe sepsis and septic shock being most commonly the respiratory tract, the bloodstream through invasive procedures, and genitounitary contributing 10%. And here we have to remember that in almost 1/3, 33% of the patients, there is never a positive culture, that we are not able to ascribe any microorganism for the ongoing sepsis. Now, certain risk factors, certain pre-existing conditions of the body predisposed to sepsis and septic shock, those being diabetes, malignancy, chronic kidney and liver disease, use of corticosteroids, immunosuppressed state, patient with burns, major surgery, patient undergoing major surgery, trauma, presence of indwelling catheter for long periods, prolonged hospitalization, hemodialysis, and extremes of age. Coming to the clinical features, since it is a continuum of clinical spectrum, so the early signs and symptoms will be those of seen in sepsis. So it's the following signs may be seen: fever, temperature higher than 38 degrees centigrade, or hypothermia, temperature lower than 36 degrees centigrade, tachycardia with heart rate higher than 90 beats per minute, tachypnea with respiratory rate greater than 20 breaths per minute. And laboratory findings, as I mentioned earlier, leukocytosis of more than 12,000 or leukopenia of less than 4,000.
Dr. Peter, can you please wind up a little bit far?
Okay. Now coming to the signs and symptoms of severe sepsis. So these are because of the end organ dysfunction, which may be altered mental status, oliguria, anuria, hypoxia, cyanosis, or ILS. Now coming to the signs and symptoms of septic shock proper. Early compensated stage of shock, blood pressure may be maintained, and other signs of distributive shock might be present. For example, warm extremities, flask capillary refill, which usually when we pinch and see, the filling time being less than 1 second, bounding pulses. At this stage, it is called as a warm shock. Here, when managed aggressively with resuscitation and vasoactive support, then the shock can be reversed. Now, when it is not reversed at this stage, it goes into uncompensated stage where the hypotension ensues despite correction with IV fluids. Thereby, the patient present with cool extremities, delayed capillary refill, and thready pulses. Now is called cold shock. Now, with continued hypoperfusion of the tissues, there may be irreversible shock. So, but what is the evidence-based medicine and what is the consensus? The third international consensus on the definition of sepsis and septic shock defines septic shock as a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. Patients with septic shock can be clinically identified by a vessel pressure requirement to maintain a mean arterial pressure of 65 millimeters of mercury or greater and serum lactate levels greater than 2 millimoles per liter in the absence of hypovolemia. This combination, why we have taken this cutoff, this combination is associated with hospital mortality rates of greater than 40%. These are the common laboratory findings which associated with sepsis and septic shock. Now coming to management. So management we divide into 3 parts, and this is according to the Surviving Sepsis Campaign guidelines. First is control of infection at the source. So broad spectrum antibiotics should be used preferably within 1 hour of diagnosis of all patients, and initially empirical anti-infective therapies should be considered, which has a broad coverage and adequate penetration of the source tissue. Then the removal of the infected necrotic tissue, which may be the source of the infection. Coming to the second part of the management, it is management of the shock, and it is most effective when it is initiated within 6 hours of diagnosis. The goals being to restoration of the central venous pressure to 8 millimeters of mercury to 12 millimeters of mercury, and restoring mean arterial pressure to greater than 65 millimeters of mercury, restoring the superior vena cava saturation or the mixed venous saturation to 65% and SBC saturation to 70%. Fluid resuscitation with crystalloids and colloids up to the level of 80 ml per kg, mechanical ventilation, which is to reduce metabolic demand of the body, and first line and to start the first line vasopressor agents. Now the third component is enhancing host response, and in which patients which are we are planning for host response enhancing corticosteroids are indicated in vasopressor refractory shock and in patients with low basal cortisol levels. And addition of vasopressin may be indicated and considered in vasopressor refractory shock. Here 2 things we need to remember is central lines are not actually required for resuscitation but for monitoring purposes, and peripheral venous axis is adequate for administration of the vasopressors. Now depending on the stage of presentation, this may be the differential diagnosis of septic shock. acute respiratory distress syndrome, DIC, distributed shock, hemorrhagic shock, adrenal crisis, cardiogenic, toxic shock syndrome, drug toxicity. Now, coming to the prognosis. Prognosis, it depends on the type of organism, antibiotic sensitivity, number of organs affected, and the age of the patient. What does the data suggest? It suggests that tachypnea and altered mental status are predictors of poor outcomes. Now, inotropes have to be used in septic shock, but the prolonged use of inotropes to maintain blood pressure is associated with adverse outcomes. In survivors of septic shock, they are often left with significant functional and cognitive defects. Coming to the complications which may proceed on after septic shock is acute respiratory distress syndrome, injury to the renal injury, DIC, mesenteric ischemia, acute liver failure, myocardial dysfunction, multi-organ failure ultimately. Thank you.
Dr. Victor, thank you for your nice and elaborate presentation regarding the septic shock. One thing I want to ask about one question is, have you ever encountered this kind of septic shock patient in your career?
Yes, we have often encountered. And patient usually takes a lot of time to recover, and there is subsequent nosocomial infections from the intensive care setup also. So it's quite a conundrum of multi-organism infection. First maybe because of our infection related to the genitourinary tract, then subsequently there will be infection through the bloodstream and through the respiratory tract also.
But one thing, I have experienced many septic shock patients, especially in the periphery, in Churasampur, in Tamenglong, even in Thawal also. But thing is that I usually do the IV fluid only. So what intravenous fluid. While giving this intravenous fluid, this suppose I don't know some substandard more maybe. So even in Churasampur also, the patient after post-operatively, suddenly patient has high fever, suddenly BP fall down 90/60, and it's very difficult to manage. I have to send it to the ICU. And before pre-operatively also, I have experienced many patients, the 3-4 patients, like in Churasampur also, in Thawal also, even in Tamenglong also. So it's very difficult, like sometimes we never get this type of thing from the nosocomial infection or nothing like that. Patient was very healthy, he was about to be operated, and then suddenly patient had high fever, and suddenly patient has to be, BP suddenly drops 90/60. So we have to cancel the OT, and then we have to give more higher antibiotic, and then we have to postpone the OT many times. See, this is what my experience. So this thing happens in our own practice.
You mean to say your sepsis duty or IV fluid that we are using? In other words, I think we have to be little, vigilant, or substandard bottles available in the market at a very reduction rate. But in such circumstances, I also came across some of the patients who are having high fever after this transfusion. So if we switch on to standard IV fluids, I don't know whether this is very tempting. The pharmacies purchase from company in a less discounted rate and then supply to the patients. So mostly we rely on the standard one, the B-prop, something like that. And I also came across like this. So many times we have the moment you give IV fluid, the temperature goes into 102, 103. And then when it changes to about ringer, it becomes okay. And we give it a puff again, and then again temperature rises again. So septicemia, there are a lot of causes, of course, as Dr. Baker has mentioned, but this IV fluid also is not given in the book. So we have to take our conscience. So any comment from the audience? Then we go. Thank you, Dr. Baker.
Thank you.
Now, I call upon Dr. Salam Hemawati. She will be talking about massive blood transfusion. Okay.
Good afternoon, respected chairpersons and my dear seniors and colleagues present here. Today I am going to speak on a topic of massive blood transfusion. So first let's define what is massive trauma. Massive trauma is an injury which has the potential to cause death. It can be either a blunt injury or penetrating injury. Examples can be of massive blood transfusion. It's going forward by itself. There is some time setting that is going by itself. So any injury, it can be either a blunt injury or penetrating injury, which is accompanied with severe blood loss, is known as the massive trauma. So massive trauma usually needs massive transfusion. So let's define what do you mean by massive transfusion. There are many definitions of massive transfusion, which is replacement of more than 10 units of red cell within 24 hours, or more than 4 units of RBC is replaced within 1 hour with the anticipation of more blood loss, or more than 50% of the total blood volume is replaced in 3 hours, or in a functional rate we can say it is more than 150 ml of the blood is lost in 1 minute. There is another term called ultramassive transfusion, where there is more than 20 units of red blood cells is transfused in 24 hours. These are the grading that we have discussed. I will not go in detail, starting from grade 1 to 4, the severity of the blood loss. The severe one when it is lost more than 40% of the blood volume, when there is marked depression of the mental status along with profound hypoperfusion resulting in organ damage and death. The primary objective of any transfusion is to prevent the fatal outcome that results from hypoperfusion and its related complications. Usually trauma requirements are very unpredictable, requiring massive blood over a long period of time, so planning is very important. There are many scores which are used. Among them, the assessment of the blood consumption score, which is depend on 4 parameters, is usually used, which is easy to use and doesn't depend on time consuming tests. And another one, shock index, which is the ratio between the heart rate and the systolic blood pressure. If it is more than 1, there is high index of massive transfusion. And the rule of 30, along with the shock index and rule of 30, is a very good parameter because it shows the acute dynamic changes in the hemodynamic instability. There are another scoring called as the critical administration threshold, when we use more than 3 units of RBC in 1 hour. Other severe injury scores are used depending on the availability of the lab parameters and the instruments that we have. So why scoring is important? Because clinical decisions sometimes delay or failure of the resuscitations. So scoring helps in identifying the patients who are real need of the volume replacement, and also it avoids unnecessary transfusion and its adverse effect associated with the blood use. So how we manage the massive blood loss? First, we restore the blood volume, try to maintain the oxygen carrying capacity, try to solve the source of the bleeding and correct all the lethal triads, along with lab monitoring and the initiation of the massive transfusion protocol. The approach of maintaining the blood volume, traditionally they used to have this aggressive approach where the key principle was to maintain the BP and blood volume, where large amount of crystalloids were used. But because of dilutional coagulopathy and its associated complications, it is not popular. Then, as a part of the damage control resuscitation, we have the hypotensive and hemostatic resuscitation. Hemostatic one is very popular with the early transfusion of the plasma. The fluids that we use normally are crystalloid colloid PRBC for increasing the oxygen content, FFP for restoring the coagulation factors, cryo, and a platelet. So which blood product is preferred, crystalloids or blood product or the blood components or products? For the mild bleeding, we usually prefer crystalloids, but for severe trauma, crystalloid alone causes dilutional coagulopathy. So it has been published or proof in many literature that using PRBC alone and delaying the use of plasma with a delay in the lab turnaround time, it leads to dilutional coagulopathy. So what is massive transfusion protocol? It is a design protocol with some algorithm which shows the proper management of the blood transfusion requirement along with proper interaction with the clinicians and the blood bank, which ensures the proper judicious use of the blood and the blood components. What is the rationale of using a blood transfusion protocol is it gives the rationale of using blood transfusion protocol is that it gives the proper blood in its proper ratio 1:1. Excuse me. Sorry. All the slides are moving fast. So the rationale of having a massive transfusion protocol is that we are giving the blood components in a predefined ratio, that is in the ratio of 1:1 with the RBC, platelet and plasma, which mimics the physiological constitution of the whole blood and prevents the dilutional coagulopathy and the hypovolemia. So this advocates or promotes the early use of plasma, which will reduce the associated complications of transfusing this cold stored blood, which leads to many complications. Many studies have shown, like in a prompt and a proper trial, where they compare the patients by giving higher amount of RBC and half of the platelets, and another one giving the equal ratio of RBC and the plasma and platelet. So in the result, they have shown that higher ratios of plasma, that is given in equal proportion of RBC, platelet and plasma 1:1 ratio, has better hemostasis and fewer deaths by blood loss in 24 hours. The criteria of having a massive transfusion protocol in a hospital depends on organization in center, the benefits of activating the protocol, and also to the reliability of predicting the transfusions is necessary, which will minimize the resuscitation. So what is the component? When and who will initiate? Notification of the blood center or transfusion services, what are the lab parameters that we have to do, what are the blood products and the packages that will be delivered, and what are the other extra care that is needed while transfusing the blood. The criteria is any severe life-threatening trauma, grade 3 or 4, or unexpected blood emergencies, or which requires or which fulfill the criteria of the massive blood transfusion can have the massive transfusion protocol. Notification of the blood transfusion center is very important because timely and direct communication will prevent the delay of issuing the blood, and also the update of the patient conditions to the blood center will allow us to properly review the requirement of the blood and setting a proper inventory of the blood management in the blood center. And also the inactivation of the massive transfusion protocol is very important because unnecessarily there will be wastage of the blood in case if they haven't been notified to us to stop the massive transfusion protocol. What are the lab parameters that usually do? We usually check all the basic lab parameters starting from the basic coagulation profile, and then if we have the facility of point of care testing like thromboelastography, that can be used. So the temperature which shows critical physiological derangement is the Main thing is hypothermia when temperature is less than 35, acidosis, acid-base imbalance, hypocalcemia, platelet count is less than 50, then adherence PTINR, and the hypofibrinogenemia. So the main aim of this massive transfusion protocol for transfusion is to normalize all this derangement in the lab parameter. What are the blood products that will be issued? First, when we receive any requisition for any release of blood, first we will do the basic protocol of pre-transfusion testing, identification of the MRD, then all the criteria have been fulfilled or not. But in case if it is a very emergency situation where it is life-saving, then first we issue O negative uncross-matched blood. But getting an informed consent from the physician is important, and the blood bag and the requisition form will be labeled properly, stating the uncross match. And we will continue the lab investigation after issuing the blood, and in case if any discrepancy is found, we will inform the concerned physician. Within 5 minutes, if we have time, then we do immediate spin cross-matching to rule out any major ABO incompatibility. Then within 15 minutes, if we have time, then we do the blood grouping also, so that we can give the blood group of the patient, so that we can save the O blood group or O negative, which is very rare or very precious in the blood center. And if we have around 50 to 30 minutes, 1 hour, then we do the full complete screening. Selection of the blood components, PRBC, we usually better to issue the group specific if we have time, if not O. Then FFP, AB plasma is given group specific, or A if AB is also not there, then with low titer NTB. Platelet also we give the AB. In the RH negative, we have to be concerned to the female of the childbearing age. If possible, we have to give the RH negative. Otherwise, to the male patient, we can issue the RH positive. So switching of the ABO RH, first we are giving O negative, but when we have to switch the concerned ABO, we have to do some tests, and for that the physician can consult to the transfusion medicine specialist, so that we can switch to the respective blood group of the patient. These are the guidelines threshold. Usually RBCs, they have no threshold for acute trauma patient or severe hemorrhages. It depends on the consultant's discretion, and the unit, usually 1 unit increased hemoglobin by 1 gram. Then platelet, if it is, we have to maintain around 50. If it is multiple trauma, 1 lakh, 1 SDP dose, which is equivalent to 4 to 6 units of the whole blood derived RDP is given. In the pediatrics child group, we give in the ratio of in the dose of 5 to 10 ml per kg body weight. FFP we give when INR is more than 1.5. Cryo is usually for replacing the fibrinogen level when the level is less than 100 milligram per deciliter. Usually the dose is 10 unit pool, which usually raise the fibrinogen by 10 milligram per deciliter. Last part, we have to give importance to the blood warmer because we are issuing a lot of cold blood. So the blood, high capacity, good quality blood warmer can be used, infusion pump, so that the speed is very important while transfusing during massive transfusion. This other thing. Then cannula size, we know larger diameter and shorter length is the highest flow rate around massive transfusion. We use around 14 to 18 gauge. Massive obstetrical hemorrhage, we already discussed, but sometimes here the bleeding can be concealed because of the amniotic fluid. It makes very difficult to accurately estimate the type, how much blood is lost. So early recognition and treatment is very important. All the component therapy in the obstetric and gynecology almost same, except that the fibrinogen level supplementation is to be done early, and the level is usually 2 gram per deciliter. So early supplementation of fibrinogen is very important by cryo, and the early use of IV tranexamic acid within 3 hours, it is very much recommended in many studies. And the use of recombinant factor 7A is controversial because of the thrombosis, and it is used as an off-label rescue therapy when all other interventional conventional measures have been failed. And nowadays the latest recommendation is to use the point-of-care testing with a thromboelastography or rotational thromboelastography, which give the goal-directed individualized component therapy by using this plastic testing. According to this obstetrical hemorrhage safety bundle, there are 4 bundles, which is defined as 4 R's. Then it is readiness, where we have all the supplies and kits and checklists with all the response team ready for the preparation of the massive transfusion. Next is the recognition and prevention. Then you assess the rates, then try to assess how much blood is lost and do the active management. Next is the response, which is the hemorrhage emergency management team plan, which give proper management. Last is the reporting, which is the learning phase. So in the FIGO also it recommends that in the PPH management, everyone should have a bundle care in most of the hospital. In children, most of the massive transfusion is, there is very less data in massive transfusion in children, and the massive transfusion is also very difficult in the children because the size of the blood volume of the infants. Usually most of the blood components are given in aliquots divided into small proportion at a dose of around 10 ml per kg, 5 to 10 ml per kg for RBC and around 10 ml for the plasma. Then some complications are there because of the massive transfusion. Dilutional coagulopathy is very common because of this consumption of the clotting factors and with the resuscitation fluids given along with acidosis and hypothermia, which aggravates. Then hypothermia is because of the rapid transfusion of the blood product, where around 10 units of red cell transfusion and 1 hour of surgery can even decrease the core body temperature to less than to decrease to 3 degrees Celsius fall in the temperature. The complications of hypothermia usually is very important because it affects the metabolic pathway, all the enzyme pathway, lactate pathways, everything is disturbed, coagulation cascade pathways affected, platelet function is disturbed, so it aggravates more bleeding, and also it has a effect on the cardiac, which causes ventricular tachycardia and fibrillation. Citrate toxicity, usually because of the anticoagulant which is present in the blood unit, it can cause citrate loading, which causes citrate toxicity, and usually it causes hypocalcemia, which can cause tetany and hypotension, and it also leads to cardiac arrhythmias, which are very fatal. So monitoring of the ionized calcium level is very important while doing a massive transfusions, and also the ECG changes. Then other complications related to blood storage, since we are transfusing a lot of stored blood, because of the stored blood, there is release of this potassium in the transfused red cell unit, which can lead to hyperkalemia, and this is lead to arrhythmia. So we have to be careful, especially in the neonates and the small young children, which are a high risk one, and this patient we have to be very careful of the hyperkalemia. Hypokalemia, then transfusion reactions like Trali-Taco, transfusion overload, volume overload, infections, then all the complications of having a transfusion reaction, we have to have a lookout. So in the summary, massive transfusion is an emergency which is accompanied by volume loss with all the complications. So having a well-developed massive transfusion protocol is very important, and its blood transfusion services should also have a maximum surgical blood ordering schedule in the elective cases in order to promote more efficient utilization of blood other than the massive transfusion protocol. So the most important thing is early detection and try to correct the coagulopathy as soon as possible with giving all the blood components in time, which will improve the outcome and saves the life of the patient. Thank you.
Thank you, Dr. Hemapati, for your wonderful and elaborate talk on massive blood transfusion. In our setting, we do encounter lots of difficulties when massive transfusion protocol requisition do come to. So, please highlight on some of the maximum surgical blood ordering schedule of gynecological cases, Dr. Hemar.
Maximum surgical blood ordering schedule is a list of the blood components that is required in any elective surgery cases, depending on the statistical data that is present in that institution. So depending on that, how much blood will be required for the any elective surgery. That is the data we have maintain, which will decide or which will prevent any unnecessary transfusion. In case if we have done a cross matching, then the blood, whether it is issue or not. So depending on that, MSBOS is maintained, which give all the list of surgery. So usually in CS cases like normal cesarean procedure, it is usually type and screen. In radical hysterectomy, they say around 3 to 4 units of the PRBC or RBC have to be kept. All other procedures, most of them, usually they are type and screen method.
So my request to our senior and my colleague fellow gynecologist, if such elective surgery is to be performed or emergency surgery has to be performed, please send the requisition form timely, so that until and unless we have blood warmer in our department, though we have already requisitioned 7 this blood warmer, it will be again inducing the hypothermia, which may be again leading to increased bleeding. So my request is again to timely send the requisition form before any elective surgery. Thank you.
Thank you, Dr. Raichandra. In our setup, I think in recent years we have seen it that much of improvements in the transfusion service. We got now fractionated platelet, fractionated plasma, and fractionated RBCs. But in a situation where there is a deficiency of fibrinogen, just like your abruptoplasty or MDIC, the fibrinogen also fibrinogen is available here. Okay.
Dr. Hemapati, I just want to ask a question regarding your indication of massive blood transfusion. You mentioned only trauma. Is it trauma the only indication for massive blood transfusion?
No, sir. It's not just trauma, as I mentioned, like any injury which causes severe blood loss starting from grading 3 to 4, which has profound effect on the hemodynamic stability. Then usually more than 25% of the blood loss is there, then it's an indication for massive transfusion.
But another, like some cardiac surgery,
Yes.
and gastrointestinal, this elective surgery only, they also use this massive blood transfusion.
Because in that procedure, there is high chance of losing blood. So I mentioned like cardiac surgery, liver transplant surgery, which has a higher indication of blood loss, because in the MSBOS even they have, most of the hospital, they have indicated around 10 units of RBC is required for any cardiac and a liver transplant.
Okay.
So these are the indications.
Okay. Thank you. Any question from the audience? I think there is no question. Thank you, Dr. Hemapati, for your nice presentation. Thanks.
A big thank you to all the speakers for such an elaborative and interesting talk on the topic SOC. May I request the chairperson to kindly felicitate the speakers. First, I would like to call upon Dr. Salam Hemapati Devi. I request all the chairpersons to kindly felicitate the speakers. First, Dr. Salam Hemapati Devi. Next, Dr. Okram Sarda. Next, I would like to call upon a respected speaker, Dr. Victor Kuman. Moving on to the last session of the day, I would like to call our esteemed chairperson, Dr. Josna Angom, Senior Consultant, Department of Obstetrics and Gynecology, Jahangir Hospital, Pune, and Dr. K.S. Paikhomba, Associate Professor, Department of Obstetrics and Gynecology, Jennings, Imphal. Requesting the chairpersons to kindly come up on the dais and chair the session.
The last session of the last day, and we have few audience who are patiently waiting to hear. May I call upon Lairenjam Dipendi Devi. She will be speaking on the topic of IV magnesium sulfate therapy, the new advances, recent advances. So Lairenjam Dipendi Devi is MBBS and MS in OBGY. She is affiliated as an assistant professor in CIJA Academy of Health Sciences in Langol and a faculty since July 22, July 23. And she's also the member of FOGSI, IOGS, IMA, MSD, Dipendi Devi.
A very good afternoon to my respectful chairpersons, to all my seniors present, and my colleagues and my juniors present today. So today I'll be speaking on the topic IV magnesium. So what is new? So let's first know what is magnesium sulfate. So we all know magnesium sulfate is an inorganic salt. So to us it may just appear to be a simple salt, but it has a magnificent role to play in our obstetrics and gynecological role. So, first of all, it is a real savior in our pregnancy-associated complications, like for fetal neuroprotection in preterm delivery, secondly, for slowing or stopping premature labor, and lastly, for preventing seizures in women with eclampsia. So, we'll be discussing one by one. So, magnesium sulfate in preterm fetal neuroprotection. So, what is its role? So, those babies that are born preterm, when compared with those born at term, have a higher chances of dying in the first few weeks of life. So, even those who survive are also having a greater risk of neurological impairment, including cerebral palsy, cognitive dysfunction, educational difficulties, and psychiatric disorders in adulthood with increased educational societal costs. So preterm and CNS injury. So we have two types. That is a pathologically known, that is intraventricular hemorrhage, which is usually diagnosed by ultrasound, and white matter injury, which is usually diagnosed by MRI. And clinically, we have the most frequently encountered CNS outcomes, that is the cerebral palsy, cognitive impairment, then the blindness, deafness, and developmental delay. So cerebral palsy, it is a disease that affects movement, muscle tone, and motor skill. So what is the prevalence, that how often does it occur? So it is 1.5 to more than 4 per 1,000 births or children of a defined age group, and even increasing due to the increased survival of the preterm infants, that is the rate is increasing. So what are the causes of this cerebral palsy? So the injury, it can be caused by injury to the developing brain, either in the prenatal period or in the perinatal period or in the postnatal period. So in the perinatal period, it can be because of rubella or a cytomegalovirus infection, or it can be because of blood or oxygen delivery to the fetus is reduced. Then in the perinatal period, it can be because of birth defects, preterm birth, intrauterine growth restriction. then sentinel events in multiple pregnancy. And in the postnatal period, it can occur because of a head trauma or a cerebral infection. So how does magnesium sulfate play a role here? So in magnesium, it is a blocker of this glutamate N-methyl D-aspartate receptor. So it causes increase in the extracellular magnesium, blocks the calcium influx into the cell, and blocks the neuronal injury. So thereby it will cause stabilization of the neuronal membrane, increase cerebral blood flow, prevention of large blood vessel fluctuations, and reduction in the pro-inflammatory cytokines, also having antioxidant effect. So what are the recommendations regarding this magnesium sulfate use for the fetal neuroprotection for the preterm babies? So FIGO recommendation in women at risk of early preterm imminent birth, that is from viability to 30 weeks of gestation, FIGO has recommended the use of magnesium sulfate for neuroprotection. And in pregnancies below 32 to 34 weeks of gestation, the use of magnesium sulfate as a neuroprotection should be considered. So magnesium sulfate should be administered regardless of the cause of the preterm birth and the number of the babies in utero. So when birth is planned, magnesium sulfate should be commenced as close as possible to 4 hours before birth. And if the delivery is planned or expected to occur sooner than the 4 hours, then magnesium sulfate should be administered, because giving magnesium sulfate, it has shown that it has advantageous effect. So the optimal regimen for giving this magnesium sulfate for fetal neuroprotection is intravenously 4 grams of magnesium sulfate slowly over 20 to 30 minutes, followed by 1 gram per hour maintenance dose. So this regimen should be continued until birth, or if the delivery does not occur after 24 hours, it should be discontinued. So according to ACOG, it has also recommended that according to the evidence that magnesium sulfate given before the anticipated early preterm birth reduces the risk of cerebral palsy in the surviving infants. And APEC guidelines, that is the Alabama Perinatal Excellence Collaborative, women with preterm labor, preterm prom, or fetal indications for delivery at 23 to 31 weeks, 6 days gestation, should receive magnesium sulfate for fetal neuroprotection. However, exclusion should be done if there is evidence of renal insufficiency or other medical conditions like myasthenia gravis, for which magnesium sulfate is contraindicated. Even WHO has strongly recommended the use of this magnesium sulfate for neuroprotection in preterm birth before 32 weeks of gestation for prevention of cerebral palsy. So here are the various international recommendations. And the dosing schedule, that is the giving loading dose 4 gram and then maintenance dose of 1 gram per hour until birth. So it is all same for all the international guidelines. So magnesium sulfate, the various clinical trials to prove the neuroprotection effect for the cerebral, to prevent the cerebral palsy. So first of all, comparative observational study. Here 100 pregnant women who gave preterm birth were studied and divided into interventional group and the control group. So in the interventional group, loading dose of 4 gram intravenous was given in 100 ml normal saline over 30 minutes, and no maintenance dose was given. So in the other group, it was taken as a control group. So the outcome is adverse clinical outcome in magnesium sulfate. So the result of the study is that infants receiving magnesium sulfate were less likely to require invasive mechanical ventilation on either day 1 or day 3 of life compared to the control group. So neonates with antenatal exposure to magnesium sulfate had more free days of respiratory support in the first 28 hours of life, hence protecting the neonates from adverse effect of excessive oxygenation, that is prematurity of retinopathy of prematurity. So another prospective observational study where 50 pregnant women who gave preterm births were taken, and then here it is a study which is conducted in Rajamudhya Medical College and Hospital, Chidambaram. So here also the study has concluded that prenatal magnesium sulfate given for fetal neuroprotection before preterm birth avoids cerebral palsy and also lowers the combined risks of fetal and infant death or cerebral palsy. So significant neuroprotection protective advantage to the neonate, and is also safe drug to use in the antenatal women. So various trials. So another comparative observational study So here also it has been concluded that magnesium sulfate is a safe drug to use in the antenatal women at risk for impending preterm. So antenatal magnesium sulfate confers significant neuroprotective effect to the neonate. So the pre-make trial. So it is a randomized control trial where the effect of magnesium sulfate on the mortality and the neurological morbidity of the very preterm newborn were studied with 2-year neurological outcome were studied. So in the interventional group, they receive a single injection of 0.1 milligram magnesium sulfate, that is 4 gram over 30 minutes, and in the control group, only isotonic sodium chloride solution was given. And the result was that there was a decrease of all the primary endpoints, that is the total mortality, severe white matter injury, and their combined outcomes, and all the secondary endpoints in the magnesium sulfate group. So the pre-make trial concluded that given its beneficial effect and safety, the use of prenatal low-dose magnesium sulfate for preventing neurodisabilities of very preterm infants should be discussed either as a standalone treatment or as a part of a combined treatment, at least in the context of clinical trial. So according to the Cochrane review, magnesium sulfate significantly reduced the risk of cerebral palsy in the child and also substantial gross motor dysfunction at 2 years of age. So according to the Society of Obstetrics and Gynecologists of Canada, so according to these clinical guidelines, it is said that for women with imminent preterm birth, antenatal magnesium sulfate should be considered for fetal neuroprotection. So what is this imminent preterm birth? So it is defined as a high likelihood of birth due to one or both of the following conditions. That is when the active labor with more than 4 centimeters cervical dilatation with or without preterm prom, or a planned preterm birth for fetal or maternal indication. So according to these guidelines, they have asked what is the cutoff gestational age for the magnesium sulfate. So although there is controversy about upper gestational age, the antenatal magnesium sulfate for fetal neuroprotection should be considered from the period of viability to the less than or equal to 31 weeks plus 6 days. So if antenatal magnesium sulfate has been started for neuroprotection, tocolysis can be discontinued. So should this magnesium sulfate course be repeated? So there is insufficient evidence that a repeat course of magnesium sulfate should be administered. So should delivery be delayed to give the magnesium sulfate course? So delivery should not be delayed if there are maternal or fetal indications for emergency delivery. So to summarize it all, that is, does fetal giving magnesium sulfate have a fetal neuroprotective effect? Yes, protecting brains of the premature babies, magnesium sulfate is recommended for neuroprotection of the fetus in women at risk of very preterm birth, and it also significantly reduces the clinical outcome in preterm birth and significantly reduces the pediatric mortality and cerebral palsy incidence. So now let's go on to the second indication, that is of magnesium sulfate, uses of magnesium sulfate, that is in slowing down or stopping of premature labor. So what is preterm labor? So when preterm labor refers to the progressive cervical dilatation or effacement that is associated with regular uterine contraction that is less than more than or equal to 6 per hour. So it is an imperative factor in fetal infant death and the second cause of infant mortality, followed by congenital anomalies. So abortion, history of cesarean section and preeclampsia are reported to be the significant cause of preterm labor. So tocolytics are used to delay the active phase of labor for at least 48 hours. So the various tocolytics, there are magnesium sulfate, prostaglandin inhibitors, calcium channel blockers, and nitric oxide releasing drugs have shown positive effect on the preterm birth. So the first report about magnesium sulfate as a tocolysis was published in 1977 and was followed by the largest case series in the literature in 1983, which provided reality-based outcomes of 355 patients who were treated with magnesium sulfate after transport from another hospital with a diagnosis of preterm labor. So here what happens, even though patient had multiple other morbidities such as amnionitis, placental abruption, premature rupture of the membrane or advanced cervical dilatation, but in singleton gestation with intact membranes, there was seen that there was 76% gain in 48 hours before delivery, and 51% gain 7 days, and 39% of them achieved a full-term delivery. So the various clinical trials regarding this magnesium sulfate used in stopping this, preventing the preterm labor. So the first is a randomized control trial of intravenous magnesium sulfate versus placebo in the management of women with severe preeclampsia. So this study aimed to investigate the effects of magnesium sulfate on delaying, enriching the active phase of labor in women with premature rupture of the membrane and the subsequent fetal complications. So here in the interventional group, 4 grams of magnesium sulfate was dissolved in 100 ml of normal saline solution, and then it was given for 20 minutes to reach the loading dose. Then they received 2 grams of magnesium sulfate, which was dissolved in 100 ml of normal saline by infusion per hour. And then an infusion was continued for 24 hours after complete cessation of uterine contractions. So here it is seen that the administration of magnesium sulfate in women with preterm labor, so what does it do? It increases the period of this, prolonging the to reach the active phase of labor by 2.7 times the same as in the control group. And in women with gestational age less than 30 weeks, magnesium sulfate leads to 77% increase in the active phase of labor, and the time change has been 87.7% and 72.7% in women with 30 to 31 weeks and 32 to 32 weeks of gestational age. So the results of this was that magnesium sulfate administration reduces the respiratory distress syndrome, and also the chance of respiratory distress syndrome in infants who had received magnesium sulfate was 80% less than those who had received a placebo. Then there was no case of chorioamnionitis and adverse effects of magnesium sulfate. So to conclude it, magnesium sulfate increases the delay in reaching the active phase of labor in mothers with premature rupture of the membrane without producing adverse birth outcomes. So another randomized control trial. Here also the primary outcome was to assess the arrest of labor with the magnesium sulfate group and the nifedipine group. So to compare the two tocolytic agents, so it was seen that arrest of labor with magnesium sulfate was better, having 87% than the dose with nifedipine group, which had 72%. So to conclude it, patients who received magnesium sulfate achieved the primary outcome more frequently. However, delay of delivery, gestational age at delivery, and neonatal outcomes were similar between the groups. So does magnesium sulfate has a protective effect in delaying the onset of active phase of labor? Yes, it inhibits the uterine contraction and delays the delivery by increasing the active phase of labor. It also arrests the preterm labor and has significantly reduces the respiratory distress syndrome. So now the third indication of magnesium sulfate uses, that is it preventing the eclampsia in women. So eclampsia is a severe progression of hypertension in pregnancy. Hypertensive disorders itself account for about 14% of global maternal deaths. They are the second leading direct cause of maternal mortality after the maternal hemorrhage. Preeclampsia and eclampsia are hypertensive disorders of pregnancy experienced by about 44.6% and 1.4% of women respectively during pregnancy and childbirth. So actually annually both eclampsia and preeclampsia, they account for nearly 63,000 maternal deaths worldwide. So hence, timely intervention and appropriate management of this detrimental condition is extremely crucial. So eclamptic seizures are a medical emergency, and they can arise after 20 weeks of gestation, either in the antepartum period, intrapartum period, or in the postpartum period. They require urgent interventions so as to prevent the maternal and perinatal mortality and morbidity. So to manage the severe preeclampsia, first of all, there is to reduce the to use antihypertensive so as to control the blood pressure, then to use anticonvulsants to prevent the seizures by magnesium sulfate, and corticosteroids to improve the development of baby's lungs. So magnesium sulfate has been used throughout the 20th century for the prevention and treatment of eclamptic seizures and continues to be used extensively. So empirical evidence supports the effectiveness of magnesium sulfate in preventing and treating eclamptic seizures. Magnesium sulfate is recommended by the WHO for women with severe preeclampsia and eclampsia and has been proven to be effective in major trials and meta-analysis. It is also cost-effective and safe and has been on the WHO essential list medicine list since 1996. So what are the recommendations regarding the use of magnesium sulfate to prevent eclamptic seizures? So according to the NICE guidelines in 2020, a loading dose of 4 gram of magnesium sulfate should be given intravenously over 5 to 15 minutes, followed by an infusion of 1 gram per hour, given as a maintenance dose for 24 hours. So if the woman has had an eclamptic fit, the infusion should be continued for 24 hours after the last fit. So recurrent fits should be treated with a further dose of 2 to 4 gram given intravenously over 5 to 15 minutes. So we not use, according to the guidelines, they said not to use diazepam, phenytoin or other anticonvulsants as an alternative to magnesium sulfate in eclamptic women. So WHO also strongly recommends the use of magnesium sulfate for the prevention of eclampsia in women with severe preeclampsia in preference to other anticonvulsants. So according to the Society of Obstetrics and Gynecologists of Canada, magnesium sulfate is recommended for the first line treatment of eclampsia, and it is recommended as a prophylaxis against eclampsia in women with severe preeclampsia. So magnesium sulfate may be considered as a prophylaxis against eclampsia in women with non-severe preeclampsia but with severe hypertension, then with patients with headache or visual symptoms, then right upper quadrant to epigastric pain when platelet count is less than 1 lakh, then progressive renal insufficiency and or elevated liver enzymes, and based on the cost considerations. So magnesium sulfate should be used in a standard dosing, that is 4 gram intravenously loading dose followed by 1 gram per hour. So according to these SOGC guidelines, routine monitoring of serum magnesium level is not recommended. Phenytoin and benzodiazepine should not be used for eclampsia prophylaxis or treatment unless there is a contraindication to magnesium sulfate use or it is ineffective. So in women with pre-existing or gestational hypertension, magnesium sulfate should be considered for fetal neuroprotection in the setting of imminent preterm birth, that is within the next 24 hours at less than or equal to 31 plus 6 weeks. So delivery should not be delayed in order to administer antenatal magnesium sulfate for fetal neuroprotection if there is a maternal or fetal indication for an emergency cesarean section. So the magnesium sulfate dosing regimen, we have the most commonly used Zuspan regimen and the Pritchard regimen. Zuspan here we give already, I've said, 4 gram intravenous loading dose followed by a continuous intravenous infusion of 1 gram per hour, whereas the Pritchard regimen we have loading dose of 4 gram intravenously and 5 gram of intramuscular injection into each buttocks, followed by a maintenance dose of 5 gram intramuscularly every 4 hours. So it is the most commonly used regimen, but Zuspan better over Pritchard. Why? Because it is found that the serum concentrations of magnesium obtained from the Pritchard regimen, it fluctuates more often compared to the Zuspan regimen. So the various clinical trials. So the MAGPIE trial, it is a randomized controlled, placebo-controlled trial where 10,141 women were taken into consideration, and in the interventional group we have magnesium sulfate was given 4 gram IV bolus, subsequently either 1 gram per hour IV infusion or 10 gram IM bolus was given, followed by 5 gram every 4 hours, which was continued for 24 hours. So according to this, the outcome measures where the primary outcome was to find out eclampsia, then death of the baby before discharge from hospital, and there were several secondary outcomes, that is serious maternal morbidity, toxicity and other side effects of magnesium sulfate. So it is found that with usage of magnesium sulfate, the eclamptic fits were, the number of eclamptic fits were decreased in those with patients given magnesium sulfate than the placebo group, and also the number of fits seems to reduce with the patients with magnesium sulfate group. And these were the various secondary outcomes. So the interpretation from this trial is that magnesium sulfate halves the risk of eclampsia and probably reduces the risk of maternal death. There do not appear to be substantive harmful effects to mother or the baby in the short term. So, magnesium sulfate in preventing seizures in women with severe preeclampsia. Yes, it prevents the progression of severe preeclampsia to eclampsia. Also, 58% lowers the risk of eclampsia by using magnesium sulfate. Also, reduces the maternal mortality, and it is superior over other competitors, and no substantive harmful effect to the mother or the baby. So despite this clear benefit of magnesium sulfate, and despite the well-established superiority of magnesium sulfate in the management of severe preeclampsia and eclampsia and other conditions, it still continues to be used suboptimally in India. So there is a study which was carried out in India to find out the reason for a suboptimal use of magnesium sulfate. So it was done in a healthcare facility in 2 selected districts of North Karnataka, India. So here the varied dosage, the study says that varied dosage schedules confuse the practitioners who may not be familiar with the magnesium sulfate. So the strength of the drug formulation also varies, and achieving the correct dilution for IV administration may be prone to error and confusion. So in this study, they found that the health facilities had different strengths available, and they used many different dose schedules. So it is important that there be a standard formulation and requirement for adherence to standard dosing schedules to increase appropriate use and optimize the action. So in this case, ready-to-administer solution will resolve the errors in dosage calculation and associated complications. So observations and care. So what are the things we need to observe and care during while giving magnesium sulfate infusion? So in those with more than 26 weeks of gestation, continuous CTG monitoring can be done. And if less than 26 weeks of gestation, 30 minutes auscultation can be done, maternal auscultation can be done. And in the mother, observation of the respiratory rate every 30 minutes and blood pressure monitoring every 30 minutes, maternal pulse and urine output can be monitored hourly, and reflexes, deep tendon reflexes can be monitored, especially the patellar reflex. So measurement of serum magnesium level is not necessary unless there is sign of toxicity. So what are the signs of toxicity of magnesium sulfate? When the signs of toxicity are when the respiratory rate falls below 10 per minute, or there is muscle paralysis, reflexes absent. So in case of suspected toxicity, we can cease the infusion and take the blood measurement for the magnesium sulfate level. And treatment can be given for this magnesium sulfate is by administering calcium gluconate, that is 10% calcium gluconate IV over 10 to 20 minutes can be given. So there are various levels at which magnesium sulfate toxicity can be noted. The therapeutic range is 5 to 9 milligram per deciliter, whereas by when it becomes more than 9, there will loss of patellar reflex will be seen. When it exceeds more than 12 milligram per deciliter, there will be respiratory paralysis, and by more than 30 milligram per deciliter, then cardiac arrest will occur. So now we can say that magnesium sulfate is a real savior in pregnancy-associated complication, for fetal neuroprotection in preterm delivery, secondly for slowing or stopping premature labor, and lastly for preventing seizures in women with eclampsia. Thank you.
Very lucid presentation indeed. Any questions from the audience?
In one of the meta-analysis that you have, wonderful presentation, Dr.
Thank you, sir.
In one of the meta-analysis for users of IV Mexal in preterm labor, I would like to know whether there was no complications with regards to the fetal, because you've highlighted that you have to use for another 24 hours after cessation of contractions of uterus. Were there any occurrences of maternal complications with this prolonged use? Or if so, how much?
Prolonged use, sir, if it is used in the correct therapeutic dose, there is minimum dose to obtain the required effect.
No. In this meta-analysis, was there any mention of any complications, maternal complications?
Okay, sir, I'll just...
Yes.
I think this study, sir, you have mentioned.
So I will share these questions. So it is recommended that in many of the textbooks it said that you should not
give this magnesium sulfate more than 48 hours. So we should stop. It's better to stop after 48 hours, about after 24 hours. And doctor,
usually how many hours even toxicity develops?
it is recommended it should not be given not more than 48 hours. It should be stopped between that.
Hello? We have seen patients having toxicity even well before 24 hours. We had to interrupt actually. But we have got clinical criteria to see the toxicity. There's no need for serum estimation of magnesium. Another additional information I would like to convey to the House is it is considered as one of the first line therapy for patients in the peripheral healthcare setting like primary health center. They can push the loading dose and send the patient with IV line. That is recommended by the National Rural Health Mission. It will help save lives. And some of the material complications we came across with magnesium sulfate are, number one is they may require ventilatory support. But this ventilatory support is more frequently required on patients with either diazepam or phenytoin, much less in Maxal. And maternal mortality is much lower in Maxal. In terms of neonatal mortality and morbidity, it is almost same.
It's a wonderful drug, and that she has rightly pointed out, it can prevent neurological problems and other things also. But I'm wondering, when I was in RIMS, many times we asked for the pharmacies regarding the availability or supply chain of the drug. It is not available, and they didn't keep it. Probably it is very low, price is very low. I think profit margin may be less, and another thing is that expiry is very short. So as a result, many of the pharmacies didn't put up. So we decided one day, those pharmacies who do not put this Maxalt in their stock, we will blacklist them. So I don't know, the present situation in and around RIMS and Jennings.
So I remember when I was in RIMS and I used to order Maxalt for my personal use for the patients when I'm on duty just to be safe. One question that I want to ask Dr. Dipenti is, do you have collaboration with the neonatologist when you decide on the lower limit of gestation when you plan Maxalt therapy for neonatal neuroprotection? What is the lowest cutoff in your institute? Do you have a consultation with the patient, the neonatologist, and the treating obstetrician, and counsel them as to what the outcome is expected? Because giving Maxalt is not everything. You still need to counsel the relatives about the long-term neurological sequelae that can happen.
Ma'am, currently, so ma'am, we are using magnesium sulfate, though it is recommended for fetal neuroprotection, but basically to prevent the eclamptic fits. So main indication which we are using currently following is for that purpose.
Okay. So in our institute, I always make sure that we have a consultation with the neonatologist and the patient party, the parents, and then we start neuroprotection from 26 weeks to be realistic, and we give the protection till 34 weeks. So till 34 weeks completion, we do give neuroprotection, the same regime that you have said, and we get good results.
Okay, taking an advantage of gathering with so many professors and learned persons, Dipti, I would like to get some more details regarding the neuroprotective. You said that if the delivery is not accomplished, then you stop it. But I wonder whether you should continue this infusion till the baby is delivered.
So actually continuing for a prolonged period will have actually giving higher doses, that is prolonging the duration of magnesium sulfate has side effects on the fetus, adverse effects also.
So if my question is, do we need to continue this infusion in the intrapartum till the baby is delivered? Say suppose you are giving the you are giving the infusions, then baby, that this magnesium sulfate it has got a tocolytic effect. Now, labored, it is continue, and in one of the study, in the Canada study, probably I have not mistaken, you said that repeat dose is not required.
Not required.
So my question is whether this effective, this magnesium protective effect is to be continued when you give this during the time of the delivery. In the second stage, till the second stage.
Sir, actually, if it is within 24 hours, then it is continued from the starting of the dose. So if you exceed more than 24 hours, that is given for a prolonged period, then there can be adverse effect to the fetus like skeletal dysplasia can be there, side effect to the fetus, hypocalcemia can be there to the fetus. So if giving for a prolonged period, like prolonging the duration means giving increasing the dosage to the fetus also during intrapartum period.
Can I just add to this? So in most of these cases there is complication, like you have a Doppler change, there is fetal insufficiency, placental insufficiency, or whatever the reason is for which we need intervention and delivery. So then we plan the therapy when we have already planned it, like we are going to deliver within 24 hours. Most of the time is a cesarean section, so there is no question of continuing the Mexal therapy for over 24 hours. So what we say is that you have a better neuroprotection when you start or initiate the therapy and complete 24 hours and then plan the elective section, and that's how we finish. Once the delivery has happened, then there is no need to continue with the Mexal therapy. Yeah. So in case if it is preterm and if the tocolysis is effective enough to arrest the labor, then that's the end point again.
Okay, so congratulations, Dr. Dipenti.
Thank you, sir.
You have presented well, and your data and the reference collections are excellent. So the next speaker is Dr. Lenin Luang. So he will speak on Apla syndrome. So Dr. Thopam Lenin Luang, he got his post-graduation from GMAT, Chandigarh. Now he has been trained in minimal access surgery from the World Laparoscopic Hospital, Delhi, NCR. And he is the lifetime member of World Association of Laparoscopic Surgeons. Now he is working as a specialist in Manipur Health Services. Now, Dr. Lenin, the floor is yours.
Thank you, sir. Respected chairpersons, respected seniors, my colleagues, and my junior. Today I'm going to talk about the Apla syndrome. Thrombophilia, as we know, there is a state of hypergravity, and there are two types of thrombophilia, inherited and acquired. And Apla syndrome is one of the acquired thrombophilia. Apla syndrome or antiphospholipid syndrome is a systemic autoimmune disease characterized by production of antiphospholipid antibodies directed against phospholipid binding proteins. Incidence is very less, at nearly 2.1 per 1 lakh population. It causes arterial and venous thrombosis and pregnancy loss, and there is multi-system involvement. Apla syndrome is divided into two, primary and secondary. Primary is the one in which there is no other recognized autoimmune disorder, and secondary is the Apla syndrome which occur along with a non-autoimmune disease like SLE. And in patients with Apla syndrome, around 40% is associated with SLE. Some factors which induce Apla formations include infections and drugs. In infections like Borrelia burgdorferi, treponema infection, HIV and leptospira, and drugs which include chlorpromazine, procainamide, quinine, etc. However, there may be some low level of Apla is present in normal individual. There are three markers in Apla syndrome: lupus, anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1. Of the three, lupus anticoagulant has the strongest predictor for adverse pregnancy outcome. And the lupus antigen detection is by functional assay, and the other two, anti-cardiolipin and anti-beta-2-glycoprotein 1, they are detected by ELISA test. Pathophysiology of Imphal syndrome is explained by two-hit thrombosis model. As we all know that to activate the coagulation cascade, we need a trigger which causes injury to the endothelium. So the first hit is the injury to the endothelium, and the second hit is the formation of thrombosis. Although there is presence of anti-beta-2-glycoprotein, but if there is no injury to the endothelium, then the patient will not have any symptoms. Smoking is one of the important triggering factor causing injury to the endothelium, and so smokers, a population with smokers has a high chance of developing syndromes. And when there is no other known cause for endothelial injury, then there may be a redox balance disturbance in the vascular bed that may prime the endothelium. And in patients with Imphal syndrome, there is low level of reduced protective and non-immune beta-2-glycoprotein 1 is seen. The main pathology is the decrease in the nitrite. The endothelial nitric oxide synthase expression is decreased, resulting in generation of peroxynitrate and superoxide, and it also results in monoxide addition and inhibition of the nitric oxide mediated atrial relaxation. Phospholipid antibody disrupt the mitochondrial function and neutrophil and monocyte, which lead to increased reactive oxygen species expression and tissue factor. And if there is tissue factor expression, then the extensive pathway of the coagulation curve is activated, leading to thrombosis. Complement activation and inhibition of fibrosis also occur. Pathophysiology of pregnancy loss can be explained by formation of intraperitoneal thrombosis, activation of the complement pathway, interference of the trophoblast growth and differentiation, impaired trophoblastic invasion, and decreased production of hormone. Clinical suspicion, in whom we should suspect one or more adverse outcome related to pregnancy, and occurrence of one or more unexplained thrombotic and thromboembolic event on unexplained thrombocytopenia or prolonged coagulation time. Other clinical features, there are other system involved are there. I won't go wrong. And diagnosis. On diagnosis of Imphal syndrome, we followed the Signic criteria 2006, which is a revised Sapporo criteria that was formed in 1999. In this criteria says at least one clinical and one laboratory criteria must be present to label the patient as Imphal positive, having Imphal syndrome. Clinical criteria includes vascular thrombosis and pregnancy outcome. Clinical criteria, when there is one or more clinical episodes of arterial, venous, or small vessel thrombosis in any tissue or organ confirmed by imaging, Doppler studies, or histopathology examination. And pregnancy morbidity, when there is one or more than unexplained death of morphologically normal fetus more than or equal to 10 weeks of gestation, or when there is one or more unexplained premature birth of morphologically normal neonates less than 34 weeks of gestation because of severe preeclampsia or eclampsia or placental insufficiency, or when there is 3 or more unexplained consecutive spontaneous abortion less than 10 weeks of gestation, excluding the maternal hormonal abnormalities and maternal chromosomal abnormalities. Laboratory criteria, there are 3. The presence of lupus anticoagulant in plasma on more than or equal to 2 occasions at least 12 weeks apart, or the presence of anti-cardiolipin antibody, IgM, either or present in serum in medium or high titer, at least more than or equal to 2 occasions and at least 12 weeks apart. Or the third is the presence of anti-beta-2-glycoprotein 1 antibody in high serum level on 2 or more occasions at least 12 weeks apart. Other laboratory tests which may be done to look for thrombocytopenia, anemia coagulation profile, increased ESR, and some specific tests for SLE also can be done in patients with Imphal syndrome. And when patients with multiple thrombosis event occurs or pregnancy loss, then other conditions which cause hypercoagulable state, that means the causes of the inherited thrombosis, should be looked for. Obstetric complication includes recurrent pregnancy loss, early fetal death, stillbirth, premature birth less than 34 weeks of gestation, preeclampsia, severe preeclampsia, eclampsia, placental insufficiency, abruptio of placenta, Halep syndrome, and IUR. Patients who develop severe preterm preeclampsia less than 34 weeks has a strong association of the EPLA. Medical complication includes thrombosis, and in thrombosis, venous thrombosis is more than arterial thrombosis, comprising about 65 to 70%. Lupus anticoagulant is positive in around 2% of all thrombosis, and most common site of thrombosis occurs in the lower extremity. However, it can occur in any part of the vessels. The rate of recurrence of thrombosis is nearly 25% per year in untreated patients with EPLA syndrome, and risk of thrombosis is significantly increased during pregnancy, around 5 to 12%. Arterial thrombosis, it can occur in atypical sites like retinal artery, subclavian artery, digital, and or brachial artery. Stroke is most commonly occur if the middle cerebral artery is involved. In EPLA syndrome, they are present in around 4 to 6% of otherwise healthy individuals with stroke occurring in patients less than 50 years of age. Others like transient ischemic ischemia, amyloid plaque, and coronary occlusion can also occur. Autoimmune thrombocytopenia occurs in around 40 to 50% of patients with EPLA syndrome. Some other medical diseases are also involved sometimes. There is one life-threatening variant of antiphospholic antibody syndrome is there. It's called catastrophic antiphospholipid syndrome, or CAPS. It is indicated by rapid involvement, rapid onset of the symptoms, and involvement of multi-organ system and thrombotic event, both microvascular and large matter involvement. Approximately 1% of patients with EPLA syndrome develop CAPS. Mortality is very high in CAPS, which is around 48%, and there are some factors which trigger CAPS, including infection, surgery, trauma, malignancy, anticoagulant, withdrawal, pregnancy, or flaring up of autoimmune disease. Some important lab abnormalities to be mentioned in CAPS is thrombocytopenia, microangiopathic hemolytic anemia, DIC, and increased level of ferritin. There are many recommendations I am putting up ACOG 2012. In whom should we look for or should be tested for antiphospholipid antibodies? Patient or person with any prior unexplained arterial or venous thromboembolism, a woman with new arterial or venous thromboembolism during pregnancy, or there is history of venous thromboembolism who have not been tested before. Obstetric indication for antiphospholipid testing: either there is a history of one fetal loss, 3 or more recurrent embryonic loss, or there is this one. There is no sufficient data to support that screening of EPLA and treatment of the woman for EPLA in a woman who has already developed preterm severe preeclampsia and early onset of placental insufficiency. Management includes pregnancy management and thrombosis management. This is thrombosis management in a patient who is positive for EPLA and who has no history of thrombosis or pregnancy loss. Then thromboprophylaxis is still debatable. And associated EPLA with SLE, hydroxychloroquine is recommended, and low dose aspirin can be added. Patient with EPLA positive who has high risk profile, low dose aspirin is recommended, and the patient with EPLA with a thrombotic event, warfarin is recommended with a goal of iron maintained form between 2 to 3. If patient is intolerable to warfarin, it can be switched to low molecular weight heparin. And patient with recurrent thrombosis, warfarin with iron goal of more than 3 is considered. Pregnancy management, the goal is to improve maternal and fetal neonatal outcome. Here, the role of pre-conception counseling becomes important, and surveillance during pregnancy to ensure the fetal well-being and to avoid maternal complications is important. Warfarin is contraindicated, as we all know, it has teratogenic effect. Other drugs like low molecular weight heparin and unfractionated, they are safe in pregnancy because they do not cross the placenta. However, in between these two, low molecular weight is better because of its better bioavailability, longer half-life, so convenient for a single dose, and most importantly, it has lower risk of thrombocytopenia and osteoporosis. And for patient with EPLA positive female, but there is no history of arterial or venous thrombosis, if it is a first pregnancy, then no treatment is recommended. And if there is history of single pregnancy loss less than 10 weeks, still no thromboprophylaxis is indicated. But there is history of multiple pregnancy loss at more than 10 weeks, multiple pregnancy loss, then low dose aspirin plus prophylactic unfractionated heparin or low molecular weight is indicated throughout the pregnancy. When there is more than one pregnancy loss, more than 10 weeks of gestation, then low dose of a plus therapeutic dose of unfractionated heparin or low molecular weight throughout the pregnancy plus 6 weeks with postpartum. In EPLA positive pregnant female with past history of thrombosis and venous thrombosis, then low dose aspirin plus therapeutic dose of unfractionated heparin or low molecular heparin throughout pregnancy, and after delivery, she will be shifted to warfarin for lifelong treatment. Here we hear a little bit about low dose aspirin. Many of the international society, they have recommended from 75 gram to 150, and these are different society. And I would like to bring here one trial called aspirin trial. This is a large study, and it demonstrated 150 milligram of aspirin taken daily starting from 14 weeks of gestation. It prevents 62% of preterm preeclampsia. And another latest published systemic review of meta-analysis in AGOG July 2003, it also said that aspirin dose ranging from 150 to 160 milligram daily was associated with a low risk of preterm preeclampsia than an aspirin dose of 75 to 81 taking daily. And the regimen for anticoagulation regimen, prophylactic, here I'm writing the most common enoxaparin 40 milligram and therapeutic enoxaparin 1 milligram per kg given 12 hourly. And prophylactic for unfractionated ranging from 5,000 to 10,000 according to the trimester, and therapeutic unfractionated 10,000 or more, keeping in mind that the target is to achieve the FPTT in between 1.5 to 1.5 to 2.5 times the control, and that is to be measured after 6 hours of giving injection. And this low molecular weight heparin, when we are using, we don't need to monitor any blood parameter, but when we are using this unfractionated, we have to monitor this FPTT time. So long-term management of EPLA syndrome is necessary. Why? Because it leads to thrombosis and stroke in late future. So, but in currently there is no recommended criteria there from which we can predict the development of recurrent thrombosis once the treatment is discontinued. So identification of risk factor is risk factor, this prothrombotic risk factor, they are important for long-term management of this EPLA syndrome. Pregnancy and use of estrogen-containing OCPs appear to increase the thrombosis, and in long-term management approach, it should be a multidisciplinary approach involving rheumatologists, hematologists, and neurologists. So overall prognosis is good, and what are seen in primary and secondary, but the morbidity is more in the later. This is a secondary. Overall survival, 10-year survival is 90 to 94%, and however the morbidity is more. Let's say the example is 30% of patients developing permanent organ damage and around 20% of patients developing severe dysphagia in 10 years. But the poor prognosis include CAPS, pulmonary hypertension, neuropathy, etc. Now, what is the latest in this EPLA criteria? This one is the latest. It came up in August this year, 2023. The joint ACR and Euler antiphosphotic syndrome classification criteria. Actually, this criteria came up. We cannot discuss much in here, but they have modified it. Actually, it is modified from the Sydney 2006. They have put two domains. One is clinical domain and one is laboratory domain, and they have given score ranging from 1 to 5 in clinical domain and 1 to 7 in laboratory domain. And they have classified that if more than or equal to 3 points from one clinical criteria and 3 or more points from this laboratory criteria, then they label it as EPLA syndrome. But this one is a new study, and what is the difference between this new study and the previous classification is that the specificity of this new criteria is more. The specificity is 99% compared to 80% of this Sydney, but sensitivity is less here. It's like 84% compared to the Sydney. The main aim of this development of this new classification criteria is providing high specificity and strong foundation for future EPLA syndrome. And in some years down the line, this criteria will become famous and it may replace the Sydney syndrome also. Thank you.
The dosage for low molecular weight heparin is based on the weight of the patient. So we don't have a one dose that covers everybody at 40 milligram.
Yes,
so anybody who's less than 50, 20 suffices as a prophylactic dose. Between 50 and 90 you can give 40 milligram. 90 to 130 is 60. Above that it goes by per kg body weight. So that so if we give a blanket cover of 40 for people who are very morbidly obese, it may not cover. So we need to be careful of that.
Yes.
questions are invited from the audience. Dr. Lenin here, one comment from my side. What is the obstetric indications of sending this investigation?
Yes, sir.
Yes.
So when there is a
This
pregnancy,
APLA
so when there is pregnancy loss more than 10 weeks, any pregnancy more than 10 weeks, we'll send for APLA. And when there is more than 3 pregnancy loss less than 10 weeks, then we'll send for APLA.
But I believe that according to the new recommendations, that if it is more than 10 weeks, and it should be, ultrasound should be there,
Yes,
and
sir.
morphological normal for all the
Sir,
morphologically
yes, sir.
normal baby.
Yes, sir. I have mentioned in the presentation that morphologically, it should be, the fetus should be morphology, and it should be confirmed by either direct examination or ultrasound.
Okay, congratulations, Dr. Lenin, again.
Thank you, sir.
So, your presentation was excellent, and most of the points you have covered. So, once again, I congratulate you.
Thank you, sir.
So, if there is anything left to add, so we'll end here.
I request the chairperson to kindly felicitate the speakers. May I request Dr. Lenin on the stage? Now, I would like to call upon Dr. Deventi. Thank you, ma'am and sir. Now, as we draw close to the end of the insightful scientific session, we express our sincere gratitude to all the eminent speakers gathered here today who graciously shared their expertise and experiences with us. Thank you to our esteemed audience for your active participation, making this scientific session a vibrant pool of knowledge exchange. It has been an intellectually exciting experience, and we trust you all depart with a better understanding and fresh perspective on our focus topics today. Thank you. Now I call upon Dr. Pratima to felicitate the winners of free paper and poster presentation.
Good evening to all. We are all running late, but before giving the vote of thanks, I just want to announce the prizes for the posters, pre-paper and the quiz. We have first prize, second prize and third prize, and we would like to appreciate them with the certificates. First, I would like to call for the pre-paper presentation. We have the first prize for the Dr. Basanti for Regional Institute of Medical Science. For this, I would like to call Sir Rameshwar Singh to give away the prize to Dr. Basanti. Second to third, Sir, please, I would like you to give prize. Second prize for... The second winner and prize goes to Dr. Merlin Marita from Regional Institute of Medical Science. And for the third prize, there is a tie, and the prize goes to Dr. Barinda and Dr. Taruni Bala. Dr. Barinda is not here. Dr. Barinda? Thank you, sir. For the poster presentation, we also have 3 prizes. Dr. Sobita, Dr. Monarika, and Dr. Cheryl Raina Taro from RIMS. And but I think we are not. They have already gone. Dr. Sobita and Monarika are not. Dr. Sobika, please come on the stage. For this, I would like to call Sir Ranjit Singh, who is the President of our Medical Council, and who is since morning tirelessly. He has been with us for the scientific program since 8:30. Thank you, sir, so much. The second prize goes to Dr. Monarika Ras from Orissa. Dr. Monarika Ras. The third prize goes to Dr. Cheryl Raina Taro. For the quiz, we would like to announce there are also 3 prizes. For these, I would like to call Sir Manglem to give away the prizes. The first prize goes to Dr. Shruti and Dr. Kritika. They are from Ranchi. Then I think they have gone. The second prize goes to Dr. Virangada and Dr. Namita Gauta. The third prize goes to Dr. Barida and Dr. Rasita Ji. Thank you, sir. Now coming to the end, and before giving the vote of thanks, I would like to call Madam Dr. Asma Rana, who has come a long way from Kathmandu, and she is here with us since the start of the program, since the workshop day, that is 22nd, and she is with us till now for the last 3 days. Ma'am, please give a few words from your side.
Good evening, everybody over here, present over here. And on behalf of all the faculties, I would like to say something that, like this time, the first time I'm here, but most of the faculties have been here for a long time. And this is the first FOGSI, I believe, and we learned that in Manipur there are more than 200 OBGYN. But they are specially trained in different subjects, even in laparoscopic surgery, hysteroscopy, and I think they are doing quite a lot better than what we are doing in Nepal, I feel. I'm immensely grateful to Pratima, who really took this opportunity. I got an opportunity to come here and see Imphal for the first time, and I was impressed by the huge lake, Loktang Lake. And I also learned that deer, Sangai is your national state animal. So many things I learned, and even like brushed up my knowledge with a very beautiful presentation made. Above all, meeting my senior professor from PGI, who is my senior, saw, because I study in PGI, I saw that more than 6-7 doctors I met or they have presented over here. Then it was such a great pleasure for me to meet all my seniors and my juniors. My colleague, I think I didn't meet any because I didn't have the Manipur. My colleague, anybody studying with, co-colleague studying with me at that time in PGI, but they were juniors. So please, I'm so blessed to be here, and I thank you so much. Thank you, Pratima, and what you say that Imphal Medical Association and the Imphal Obstetric Gynecological Society. Thank you so much. From all the participants and faculties, I would like to thank you again.
When was it you were
May I invite Dr. Digel to give the vote of thanks?
हाँ चलते चलते हाँ अदुदी हेले ना सकते यार Thank you, Karuni. I, on behalf of IOGS, like to thank our respected President FOGSI, Dr. Rishikesh Pai, Secretary General Dr. Madhuri Patel, and Dr. Alka Pandey, Vice President East Zone FOGSI, for their constant support for this conference right from the first day we have decided it. We would also like to thank the patrons, the advisors, and all the members of IOGS for their support throughout the conference. And we would also like to mention a special person for this conference, Professor M. Rameswar, Head of Department and Co-Chairperson, for allowing the organizer to use his office chamber as a office secretariat. Then to name a few members of IOGS, the organizing committee like to express our special gratitude to Professor T.H. Netajini, then Professor Helen Kamai, Dr. James Langbam, Dr. Ratna Usam, then Dr. Susila and Dr. Basanti, Dr. Vidya, Dr. O. Sardar, Dr. Gyaneswari and Dr. Dipenti, and then Dr. Romita and Dr. Falguni for their constant support during the conference. IOGS also like to thank Ms. Bena of Regional Institute of Medical Science for the support from day one of the conference in arranging all the printing and the invitation works. Last but not the least, we would like to thank all the hospitals and the diagnostic centers, the pharma companies, catering service, and even the cleaning staff for their support in making this conference a grand success. Long live FOGSI, long live IOGS. Thank you once again.